resection is associated with very high recurrence rates. And as I talked about in the previous presentation, that HCC demonstrate two coexisting disease components, that is the primary liver tumor you have to deal with and the underlying liver disease. And irrespective of the etiology and the tumor modality that you have adopted, HCC often recurs. And when you are talking of non-transplant modalities, the recurrence rates can be as high as 90% over a period of 5 years, and that has been consistently shown over the last several decades in studies from East as well as the West. So, recurrence is the bane of non-transplant treatment modalities. Recurrence pattern, if we look at, majority are early, that is within 2 years, and intrahepatic. That is the good part, that you don't get disseminated recurrence in majority of the patient, that is hardly 20 to 30% at presentation would have extrahepatic metastasis. Early recurrence is considered to be true recurrence because it is a manifestation of the microsatellites growing over a period of time, while late recurrences are considered de novo tumors arising on a background of chronic liver disease. The good part, more than half of these recurrences are amenable to treatment, and the clinical morphological features and timing of recurrence are the primary determinants that would determine the long term outcome. So, this was a very elegant study coming from the Sasan Roy's group from United States, and this was published in Annals Surgery in 2015, which they analyzed their experience of 661 resections over a period of 20 years. So, 70% recurrence rate at 5 years, 45% survival, and factors associated with recurrence were the number and size of the primary tumor, the serum AFP levels, early recurrence, then the BCL stage, and the treatment modality. So, if you have recurrence, you have lesser survival. Doesn't work, and that has been shown in the third graph. So, you have to prevent recurrence. And when you look at the treatment modalities, so when you compare embolization, ablation and OLT on intention to treat basis, resection does give you some favorable results. So, in this study, only 19% of the patients with recurrence underwent resection, but their survival outcomes were pretty decent when we compare to the other modalities, especially the non-OLT modalities. So, if you summarize all the studies that are available till now and look at the predictors of recurrence, and this is a summary of those studies. So, the main criteria or the predictors of recurrence is the size more than 2 centimeter, numbers beyond Milan, that is more than 3 tumors, presence of macrovascular invasion. If you look at the histology, it is the microvascular invasion, indistinct capsule both on imaging as well as histology, and poor differentiation. So, everybody knows that these are predictors of poor outcomes. So are the tumor markers, that is AFP above 100. There is no consensus. Some people say that AFP even above 20 portends early recurrence, but a general consensus is more than 100. PIVCA values, again widely variable cutoffs from 50 to 300 as predictors of recurrence. Then we have the markers of inflammation, that is the NLR, the neutrophil lymphocyte ratio, the platelet lymphocyte ratio, because this is basically portends or gives a picture about the inflammatory environment of the tumor, and more the inflammation, the higher the recurrence. When we look at the patient related factors, is the presence of underlying chronic liver disease, and many of these patients may die as a result of decompensation even prior to recurrence. Although it has been shown that decompensation again is associated with higher recurrence rate. Treatment related, liver resection, and that is where the surgeon score is associated with the best long term outcomes when we compare the other non-surgical modalities. So, coming to the topic per se, what are the prediction models? Numerous prediction models have been published, none of them accepted universally. Broadly can be classified into two types, that is purely clinical, that is the models that are based only on clinical parameters, and what is on in vogue these days is the composite models, which have been shown to be more accurate for as far as prediction of recurrent HCC is considered, that is based on clinical as well as machine learning methods. So, I will just highlight some of these, and this is a very elegant model which was published in the Journal of Hepatology in 2018, and it is called the early recurrence after surgery for liver tumors ERASL model, based on the experience from 6 centers from both East and the West, China, Japan, Italy, United States, and they came out after the analysis of 4,000 patients undergoing liver resection. They came out with a model, one was a pre-op model based on variables like number, size, AFP, LV index and the gender, and when we looked at the post-op model, it included the microvascular invasion. and the C index for this was pretty high. It scored over the commonly used models, that is the AJCC TNM classification, the Korean model and the Singapore model. So, in this publication it was shown, and this was externally validated in other studies and was found to be a good predictor of recurrence, scoring above the traditional models. When we look at the composite model, so this again is a representative slide of a study where a radiomics nomogram was created. It was a composite model based on the preoperative clinical parameters, of which on multivariate analysis only platelet count was found to be a predictor of recurrence, along with radiological MRI tumor characteristics and a radiomic score, which was calculated on the basis of a software. And I must admit that I have no knowledge of these softwares. It is not my area of expertise, but a radiomics nomogram was calculated, and the area under the ROC curve was quite high compared, and it was shown that compared to basic MRI features, this radiomics can capture more information and more objectively. So, this nomogram was based only on two parameters, that is the radiomic score and the preoperative PLT, and gave a very high predictive value for recurrence. This is another CT based radiomic model, and it has used microvascular invasion of the primary tumor along with the radiomic score and has shown good results. So, when we look at a meta analysis, and it looked at 38 validated prognostic scores, and in a nutshell it can be said that all of these scores and all of the predictors are based on the tumor numbers, size, the AFP value, the vascular invasion. So, almost all these scores, and it has been shown over decades and over years in myriads of studies that basically number and size are the I would say surrogate for the tumor invasiveness or the tumor biology, as the saying goes, tumor biology is the king, and you have a direct representation of the tumor biology when we look at the histology in terms of vascular invasion. Therefore, all these scores are based on this these 4 parameters with an addition of 1 or 2 above those. So, when all these scores were compared, it was found that the traditionally accepted scores, the famous ones, the BCLC, the AJCC, the CLIP, the Japanese, have a performance which is at best poor to moderate when we look at their C indices. And these 4 Chinese models, which many of us have, even I was not aware of these models because we have never used them, but they had a very good C index above 0.7 and scored above the traditional ones. But actual clinical utility cannot be like I cannot say anything, I cannot comment about it until we use them, because we are traditionally using the other models. So, coming to the second part of my talk, what are the determinants of therapeutic decision making, and I have divided them into 4 categories. That is again the tumor number and size, and this is kind of repetition of my previous talk when I was talking about resection for HCC. Underlying liver function, because majority of these tumors would have underlying chronic liver disease or hepatitis or steatosis or full blown cirrhosis. You have to look at the tumor burden in terms of extrahepatic spread, portal vein tumor thrombosis, Dr. Prashant talked about it, and then the performance status of the patient has to be assessed as in any major surgery. So, choice of treatment has to be based on these 4 broad principles, I would say. Coming to the therapeutic choices, of course, resection is on top, and it has been recommended that solitary recurrence with preserved liver hepatic function with or without vascular invasion, these would be an ideal candidate for resection. Liver transplant, yes, it scores over resection, but indications are limited. Salvage transplant, if we look at the intention to treat analysis, hardly 1/3 of the previously resected patients would be able to undergo a salvage transplant, but the outcomes are good if they are within the criteria, the accepted Milan or UCSF criteria in patients with decompensation or at least clinically significant portal hypertension. Ablation, the guidelines remain the same as for primary tumors, up to 3 tumors, none greater than 3 with preserved liver function. Embolization is recommended for patients who are not suitable for the previously mentioned modalities, and then patients who have widespread disease in terms of extensive hepatic or extrahepatic disease, or who have failed prior treatments and do undergo systemic therapies, and this is an era of systemic therapies. We have found some very exciting results from the use of systemic therapy even in very dismal situations. So, these are some of the studies where they have compared resection with other modalities. So, it has been shown in studies that repeat resection versus RFA may be having comparable outcomes, but if you go into the details of the studies, the survival in the long term was always better with resection. So, if you can resect safely, go for resection. Of course, smaller tumors can undergo RFA, performance status not good, again RFA, because it is true that RFA is a much safer treatment modality compared to resection with much lower morbidity or mortality. When we compare liver transplant with resection on intention to treat principle, some of the studies have shown that the outcomes are comparable, but again, in summary or nutshell, LT scores over resection, although patients suitable for a transplant or falling within the criteria of transplant would be much fewer compared to patients who can undergo a safe resection. RFA versus TACE, again it is like comparing apples and oranges, but RFA is superior because these tumors are smaller, numbers are few. And then this was another study which compared salvage liver transplant with resection with RFA. So, obviously liver transplant, salvage liver transplant was the winner, RR resection was a close second, while RFA was a much poorer third. And I would end my presentation with this kind of busy slide, but this is an algorithm. I won't ask you to go into the details of this algorithm, but basically it covers those 4 principles, that is presence of extrahepatic spread or not, presence of portal vein thrombosis yes or no, tumor number more than 3 or less than 3, tumor size more than 3, less than 3, and the performance status of the patient. So, this algorithm is basically considers all these 4 parameters and decides the treatment, the best treatment approach, taking all of them into account. Thank you very much for your kind attention.
Thank you. I think we can have some questions. First, panelists, any questions?
Sir, are there any predictors of recurrence beyond the Milano UCSF criteria as well, sir?
Yes, there are, like the moral score. Again, moral has 2 components, it's the Korean and the American scores, and then you have the retreat score. So, I didn't go into, because the next talk is on transplantation, but they are very definite predictors of liver recurrence of HCC after liver transplantation. But basically they are based on the same criteria, that is the number, size, AFP levels, and the histological microvascular invasion, presence of These 4 parameters form the, I would say, the foundation of all the predictive models or predictive scores for HCC, whether it's with transplant or without transplant.
Any of my co-chairmen want to ask anything? Okay, from the audience.
Thank you, Fabio Piscaglia, Italy. I think you presented several treatment options, which is quite right, and in a way you are moving for what also we are recommending in Italy, to move from the stage hierarchy. You see a stage and you decide a treatment from the therapeutic hierarchy. So you start with the most effective treatment,
yes,
the most curative treatment. My only concern is that today we don't have, or it's difficult to predict the risk of liver function worsening, because all these treatments are equally potentially good, but you have to preserve liver function, because today we have several options to treat. First line, second line, third line. So I think what we are missing here is what is the prediction of liver dysfunction, because if a patient has a risk of high recurrence, it does not mean we don't have to resect, because the high recurrence is even with ablation or chemoembolization.
So, I totally agree with you, because we are more concerned with the recurrence, but not with the decompensation as a result of these treatments. But as a broad guideline, it can be said that more invasive the treatment, the higher the risk of decompensation, and that's been shown that RFA may be, resection may be superior to other modalities in terms of lower recurrence rates, but decompensation rates are definitely higher. I am not saying that RFA is not associated with decompensation, but compared to resection, definitely lower.
I have a very
and that's why on those same lines, it has been shown that TARE may be a more safer treatment compared to TACE, because the decompensation rates with TARE, although the data is still in the gray zone conflicting, but TARE may be a safer modality compared to TACE, and definitely in patients with PVT.
I have a very basic question. We have the BCLC classification, the latest one, INASL. Now, in the recurrent situation, what is the key difference in recurrence versus, BCLC is mainly, it's not, it doesn't refer to recurrence, it's only for the primary tumor. So when it's a recurrence, what is the key difference, if at all?
See, actually people have extrapolated the BCLC onto recurrent tumors also.
Is that appropriate? Or you think that's fine?
Well, I am not sure, because as was asked by the professor from Italy, that we are not taking into account that previous treatment may impact on subsequent liver decompensation.
So we don't know, is that the answer?
Yes,
okay.
That is the
Thanks.
Just one question. For recurrence, we say early recurrence. Are we really missing a satellite nodule, especially in a patients of cirrhotics? Do we call them a recurrence, or we really miss them on a primary first hand? And at what time, what interval we say it's a recurrence, or we call it as a same? I mean, because sometimes we miss a satellite nodule, especially in a cirrhotic patients.
So I again agree with you on this account, but yes, with very good imaging, that is the contrast MRI, and subsequently the histology. Histology is the gold standard. When you have the resected specimen, you will have, if the resection margins have been good, there is surrounding liver parenchyma, you will get some idea of satellite nodules. But yes, I agree with you that in a cirrhotic background, pre-resection or pre-treatment, any modality, including the MRI, can likely miss small HCCs, small satellite nodules, especially to the tune of 2, 3, 4 mm. And that is why it has been clearly defined that less than 2 years, that cutoff has been set, that within 2 years the early recurrences are because of those so called missed satellite lesions. But as the science or technology stands today, as of today, we cannot truly call them missed, because that is the lower limit of detection for the available modalities. Maybe with newer modalities, those rates would come down.
Okay, thank you, Dr. Shaleen, for a wonderful talk and nice discussion.
Thank you.
We'll move on to the next talk now, which is on prevention and management of post-liver transplant HCC recurrence. And this talk will be given by Dr. Dharmesh Kapoor, who is a senior consultant hepatologist at Yashoda Hospitals, Hyderabad. Dr. Dharmesh. Okay, I think Dr. Dharmesh is not here, or maybe joining us later. So we'll go on to the case scenario, which will be presented by Dr. Amit Goel. Online? Okay, so yeah, we have Dr. Dharmesh then.
Yeah, good evening everyone. Can someone help me move my slides? I can see my slides full screen but not able to move them. So we all know that liver transplantation for hepatocellular cancer is one of the commonest indications for transplant worldwide, and probably accounts for almost a quarter of all registrations as well as transplant surgeries. The standard criteria for transplantation registration in the Western world have been the Milan's criteria and some more liberal UCSF criteria. Those within the Milan's criteria but with very high tumor markers are again candidates who have to be downstage before they can be considered for surgery. I think there is a glitch here. It's not
Do you
working.
want the next slide?
Yeah, I wanted the control to be with me, but somehow they were not very keen for that.
No, we'll move the slide for you.
Yeah, I think that will waste time,
Just say
and they are very. So I think the standard criteria are the Milan's criteria and the UCSF criteria, but we must understand that the Milan's criteria were given more than 25 years ago, and they were based on imaging, and in those days the imaging was not very good. However, we saw in a very small number of patients, both for Milan's as well as UCSF criteria, which was less than 50 patients, that the 5-year overall survival and the 5-year recurrent-free survival were pretty good. These next. Can someone give me the control, please? That will be easier on the time.
It doesn't seem to work, so we'll move it from here. Just say next.
So even though the number of patients in the original studies were very small, but these have been validated outside of the Milan's and UCSF criteria in the UCLA criteria, which was with a much higher number of patients and gave similar kind of results. The results from UCSF were slightly inferior to results from outside of Milan criteria. This more recent concept again talks of the same paradigm that we have heard about a number of times this in the course of the talks today, which is the number of tumors, the number of nodules, the tumor size, and the expected 5-year survival. So this is the metro ticket concept. You have to pay a high price for recurrence if you're talking of higher tumor size and higher tumor burden. So those people who are within Milan criteria but outside Milan but up to 7, again they fulfill the criteria of a decent 5-year survival, which has been pegged at more than 60%. Next. So it's important that in spite of our best efforts, the recurrence of HCC after liver transplantation is a reality, and these numbers are anywhere from 10 to 15%. However, the real life recurrence rate might be much higher because many centers perform liver transplantation for tumors beyond Milan criteria, especially in the context of living donor transplant. The mean time to recurrence is about a year, and the sites of recurrence, only about 30 to 40% of the recurrences occur in the liver, whereas the extrahepatic recurrences are far more common, and they could be in the lungs, bones, abdomen, lymph nodes, and needle tract if it has been used earlier for a locoregional therapy, as well as the brain. And some of these metastatic sites could be extremely difficult to manage. Next. So these are the various prediction models for recurrence. So this graphic tells you about 3 components. One is the radiologic factors, the serologic factors. We have access to both of these pre-transplant, and then pathologic factors are always dependent on the study of the explant. And then at the bottom of the slide, you see some novel score, which is a recent score, which also talks about the patient's characteristics as well as comorbidities. Important in this is the tumor number and tumor size, which actually tell you the burden of the disease, not necessarily the biology of the disease. The serological markers, of which the AFP is the most important one. PIVKA2 is being increasingly used by many centers, but many a times there is a discordance between the AFP and the PIVKA. The response to loco-regional therapies, the dynamic changes that you see both in imaging as well as the serological markers, some role of PET-CT, and again this is a work in progress because so far we have only been relying on the FDG PETs, but now we know there are much better ways of imaging with the different radionuclides, the tumors in whom we think the load might be higher than what we think, what the imaging is showing us, and most importantly the time on the wait list. So all of these components are very, very important to decide on the recurrence of the tumor. Next. So these are the pre-liver transplant prognostic models. You have heard about most of these. The important one which has not been covered is an NLR, which is the nucleoside to lymphocyte ratio. It's a kind of assessment of the biology of the tumor in some ways. And you can see that the recurrence-free survivals are very low in those patients who've got low score, and it's pretty high if the scores are high. Next. Similarly, we have the post-liver transplant prognostic models, again based on the same things, whatever you see on the explant. So what is the tumor diameter, the tumor number, then the viable tumor. So which is what has been the effect of the loco-regional therapy that we gave to the patient. Microvascular invasion, the degree of differentiation of the tumor, the lymphovascular emboli, and it's now become very commonplace to do the IHC staining on these tumors, and in more recent times also to see the milieu of the tumor or the tumor microenvironment, which will also give us a good handle on what the tumor biology is going to be like and what to expect from the recurrence rates of these tumors. So you see at the top of this slide the retreat score, which was given by the UCSF group, and there you can see that if the scores are very low, then these patients might not even come up for a surveillance in the post-operative period, but then this again needs to be validated by more studies. Next. So one thing which has caught my attention while I was preparing for this talk is that it's been shown that the living donor liver transplant probably scores over the deceased donor liver transplants, especially in situations in which the tumors are within Milan's criteria, which is what was shown by this recent publication, in which there was an international cohort and the Toronto Hospital cohort, which was able to do both the living donor as well as the deceased donor. So you can see that in the living donor transplant cohort, there is a zero dropout rate. And similarly, when both the two options were available, the dropout rate was extremely low, even in the living donor single center experience. And you can see that the cumulative survival was very good in both with the pre-inverse probability treatment weightage as well as post-inverse probability treatment weightage. And similar kind of an experience was seen even in patients who were in the Toronto cohort. Next. This was also shown in the cumulative recurrence after living donor liver transplant when the tumors were beyond Milan's criteria. And this was again a recent publication from 12 centers in the North Americas, where you can see that patients in whom the N.Y.C.E, the New York, California score was used, more patients could be offered living donor transplant with very good 5-year overall survival. However, what really caught my fancy was that those patients in whom LRT was used was much higher in those who were within the Milan criteria rather than who were beyond the Milan's criteria, which probably makes me feel that you are not so much keen to study the biology of the tumor than the time on the wait list. And this is something which we probably need to discuss in the context of living donor liver transplant. Next. So how do we manage patients post liver transplant recurrence? Next. So we have to survey these patients, and those who have got high prognostic model scores will probably be imaged every 3 to 4 months along with tumor markers, and those who have got low scores might not be kept under surveillance or be surveyed in a more conservative manner, which would be about 6 months with cross-sectional imaging, which could be a CT or an MR. And we've heard this morning that MR is much better to pick up smaller lesions as well as tumor markers. At times when the lesions might not be in the viscera, you might have to resort to something like PET scans, which have now scored over the bone scans. There are some thoughts on preemptive therapy, but there's only one study which I could see, which was with Lecatin, which is actually a mitoximab, something which is expressed in to a great extent in the hepatocytes, and this is a monoclonal antibody against that. And there are some studies with sorafenib, and in the non-randomized context, this was shown to be effective. However, a small randomized control trial showed that sorafenib was not effective as a preemptive treatment. Next. There is a role of the immunosuppression that these patients receive at the baseline. We all know that patients with hepatocellular carcinoma, they have mutations in the mTOR pathway, and these are seen almost in 50 to 60% of the cases. Next slide, please. The first trial, which was a randomized control trial, was with the use of sirolimus, and this trial was a negative trial, even though the recurrent-free survival as well as the overall survival were close to the confidence interval of 1, but it was that as time passed by, the next so similar kind of results were also seen with the use of everolimus in the post-transplant setting. This was the H2304 study, which was the seminal paper use of everolimus in the post-transplant setting, though not to study the recurrence of HCC, but as a collateral benefit, it was seen that those patients who were on everolimus and reduced TAC, they did much better when they were followed up for 36 months with respect to the HCC recurrence. Next. And this was the study from our backyard in which some of the centers in Delhi were also participating, which was the H2307 study, in which again reduced dose of tacrolimus and everolimus were the mainstay of immunosuppression. Next. And again, it was seen that at 24 months, the recurrence of HCC was much lower in the reduced TAC and everolimus group than in the standard TAC group. Next, please. How do we manage these patients when they do actually develop a recurrence? So the best form of management is in the form of surgery. It has also been shown that those who are managed with the curative intent, they do much better than those who are managed with the palliative intent or those who are managed with the best supportive care. Next, please. It has also been shown that the AFP values at the time of recurrence as well as oligometastatic versus greater number of recurrences would also hold sway over the outcome of these patients. Next. And the poor prognostic factors are most importantly not being able to offer a curative treatment to these patients. Next. Next please. Yeah, please keep moving. Similar experience was also seen in this North American study, wherein it was shown that when you have recurrence, then surgery is offered to a very small number of patients, especially those who are transplanted late, those in whom the recurrences appear late, and in those whom there are small number of recurrences. However, the non-surgical recurrences are the ones which are most commonly offered to these patients, and they don't do as well. Next. So I think the loco-regional therapies, again, they have been small case series, mostly retrospective, and for solitary to up to 3 intrahepatic recurrences. The recurrences might be there in the extrahepatic space too, and the re-recurrences and extrahepatic recurrences almost always occur to the tune of about 1 out of 3 over the next 3 to 5 years. RFA, microwave ablation, and catheter-based therapies have all been used, and coexisting systemic therapies have also been used as a co-therapies with these modalities. Next. The systemic therapies have been the mainstay of treatment in the post-transplant recurrence, and in this the TKIs have really ruled the roost, and the studies have been there with sorafenib as well as when there is a progression on sorafenib with regorafenib, and one has shown that in meta-analysis the median survival after sorafenib use has been to the tune of 12 months, and regorafenib following sorafenib has been to the tune of 28 months. There is not much published experience with the use of lenvatinib, cabozantinib, and ramucirumab. Next. The ICIs in the post-liver transplant recurrence have been something which has caught our fancy, but we must understand that they unleash the host T-cell immune response. The T-cell mediated rejection is seen in up to 15 to 40% of patients. The HCC progresses in about 50% of patients at 6 months, and 65% of mortality is seen at 6 months. Next. It's very important that we do not start these treatments early. Most of the studies have shown the rejection rates and IRAIs to be less when they are given 2 to 8 years after transplant. So the timing of use is very important. The CTLA4 inhibitors are probably better than PD-1, but inherently we know that the PD-1 inhibitors are the ones which have been commonly used in this context. The background immunosuppression is extremely important. You want to lower the immunosuppression so that your T-cell response would be better, but at the same time there is a risk of rejection, and therefore this is a very tight rope walk. It's also been suggested that you might want to biopsy these patients pre-initiation of ICIs and stain the tissue for PD-1, and if the PD-1 staining is high, then these are the patients who have got a high chance of rejection, and therefore you should have some kind of a uptick on their immunosuppression in the baseline. Next. So to summarize, ladies and gentlemen, we must make a distinction between the primary and early and late recurrences of HCC after transplant. All of these probably have a different biology, but we probably try to paint them with the same brush. The mainstay of management has been an early pick of these cases through surveillance, and when we have picked them up, to try to treat them in a definitive manner, which is surgery. But unfortunately, the studies on surgical management of recurrent HCC have been very few and far between. None from our country so far, even though we've been transplanting for more than 20-25 years, and maybe the chairpersons and moderators would want to comment on that. The immunosuppression post-liver transplant is extremely crucial, but most of the studies have actually talked about the use of mTOR inhibitors 4 to 6 weeks into transplant. So what is really not very clear is whether it is the absence of CNI or the presence of mTOR inhibitor, which is the important determinant for preventing in a kind of an adjuvant manner the recurrence of HCC. The management strategies are not streamlined. You heard from the chairperson a little while ago that we try to extrapolate the BCLC even for recurrences, and that's probably what we have been doing in this context. When you are transplanting whole grafts in the DDLT context, you might still open a very exciting field of research, but safety remains a concern. But the overall prognosis in these patients remain dismal, and therefore it's extremely important not to just talk about the tripartite the equipoise, but the quadripartite equipoise also, wherein the healthcare resources that are used after transplant also are extremely important. Thank you very much.
Thank you, Dr. Dharmesh. Questions? Can I ask you a question?
Yeah, please.
So you talked of surveillance to look for recurrence after transplant. So how frequently would you do a imaging and till when, like for how many years?
So I think we image them every 6 months for the first 2 years and thereafter on an annual basis till 5 years. But in recent times, we have seen patients come back with tumors even after 5 years. But that's been our current strategy, and the tumor markers would actually depend on what the tumor markers were like pre-transplant, but they are done more frequently in the first 2 years every 3 months. We still use both AFP and PIVCA, though I can't still wrap my head around why the two of them might be discordant in certain situations.
And do you think the tumors, recurrent tumors are slower in terms of tumor biology as compared to primary tumors? Like they grow slower as compared to primary?
So I have not, I would say from experience, probably what you are saying is yes, but I don't think this has been studied well, and that is why my first statement on the summary slide was that we probably think that the primary versus early versus late recurrences are all the same. But now we have at least some initial clues on what the transcriptomics are with respect of the primary tumor as well as early and late recurrences, and that will go a long way in defining how we manage them. But to cut the long story short, probably they grow slower than the primary tumor.
Yeah, that's probably our experience also.
May I have a question, please? Regarding the various predicting models of recurrence, including retreat score, the microvascular innervation is given importance, ample importance, but unfortunately we get it from explant histology. As you would recollect, Toronto criteria, the extended Toronto criteria, they used to do a liver biopsy to look at the nuclear grading as well as microvascular invasion. Now that there is a resurgence of interest in liver biopsy, do you think liver biopsy done before transplant, given the fact that the needle tracking, needle seating and all is less than 1%, will it be beneficial? Is it time to call back liver biopsy prior to transplant to predict recurrence?
So I think you're absolutely right. They biopsy the largest lesion, but that's only the experience from one center. I have not seen any other center pursue the same line of thought, and that's my concern with that. I don't think many of us would be very keen to get into a vascular tumor pre-transplant. I think we, at least at our center, we biopsy only those patients whom we are writing off, and in recent times, those patients who go on ICIs, we have been biopsying them, but that's for a completely different reason. So I think we still not their prime time to biopsy tumors pre-transplant.
Thank you. If there are any, I think we need to move on to the next session, which is a discussion of case scenario. May I invite Dr. Amit Goyal.
Good afternoon, everyone. I'll thank the ILBS team for giving me this opportunity. So we will discuss an interesting case of hepatocellular carcinoma. It was managed, evaluated in ILBS. Dr. Chandan, my colleague from ILBS, will present the case, and then we will take the discussion forward. Dr. Chandan, please.
Good evening, respected House. Case is a 53-year male who came presented to us in 2021 with the diagnosis of portal hypertension with the small superciliary varices and cirrhosis. That was hepatitis B related with the DNA log value log 2 with MELD score 22. Patient was followed up, and in February 2022, patient had new onset ascites, and that time patient was screened and found having LR3 lesion in segment 7 and segment 1 of size 2 into 1.4 centimeter, for which patient underwent in June 2022 with staging laparotomy and with LDLT. And the explant was sent for the HP analysis, and found just segment 8 in segment 8 4 into 3 into 1.5 centimeter tumor with and segment 7.8 into 0.3 centimeter. In segment 6, there was a 0.5 centimeter tumor was there, and that was the nature was combined hepatocellular cholangiocarcinoma that was moderate grade and only limited to the liver. And patient was again lost to follow-up from ILBS and was showing in another center for the further immunosuppression, and presented to us in July 2023 again with the shortness of breath. And that time patient was screened and followed up. So pre-transplant value was hemoglobin was 10 with a 5.6,000 of total count, with platelet count 1,55,000, with creatinine was 1.1 with urea 32. Total bilirubin was 1.07 with direct component 0.3, and INR was 1.32. That time AFP and PIVCA was 20 and 200, and CA99 was 28. That time CT was done, sir, and CT was showing liver SOL with liver SOL with lung and bone metastasis. In bone, there was vertebral metastasis of L1 lateral of the body. We did US guided FNA from both lesion and lymph node, and both was suggestive of combined SCC and cholangiocarcinoma. And that time immunosuppression was going on was tacrolimus 1 mg BD and everolimus 0.5 BD. Final treating diagnosis was post-LDLT with the right lobe graft, HBV related with the hepatocholangiocarcinoma, with portal vein graft RPV to MPV, and arterial anastomosis was there was a RHA to recipient LHA. Biliary anastomosis was 2:1 anastomosis, and post-LT hepatocholangiocarcinoma recurrence of size 5.9 into 4.1 into 5.2 centimeter. That was subdiaphragmatic region in and lymph node, lung and bone metastasis. And that time also AFP was 20 and CA was 5.3 and CA99 was 9.9 was 359. So now.
So in this case, we had hepatocholangiocarcinoma, and I can identify certain issues where I need input from our chairpersons and moderators. So when to suspect on radiology or before surgery, before transplantation, that are we dealing with SCC or are we dealing with combined cholangio and hepato? So any comments, any opinion? Based on the clinical feature, radiology or serological evidence, we can suspect that we are not dealing with pure SCC.
Radiologically as well as serologically, there could be some indication.
Yeah. So with literature, what I could gather is that radiological feature which is not typical of SCC, like Lyrad 3 or 4 stage, which was there in our patient, was Lyrad 3. And if we have discrepancy between the radiological feature and the serological markers, means we have radiological evidence of SCC, but AFP is not elevated, rather CA99 is elevated, or both markers are elevated, especially CA99, or there is dilatation of bile duct, atrophy of lobe, or there is puckering of the liver capsule, those things which are suggestive of cholangiocarcinoma. So we may keep our antenna up that we might be dealing with the combined tumor. And if we have done pre-op biopsy, then the immunohistochemistry staining can help us that we might be dealing with the combined tumor. HepAR1 and glypican 3 is for SCC, and CK7 and 19 are for cholangiocarcinoma. Second issue, so this we have discussed, that our patient had these findings. Second is how this combined tumor is different in behavior-wise as compared to the pure SCC. So, sir, comment?
I think they may behave a bit atypically, may have a more chances of recurrence, I would say.
Yeah, so literature suggests that these combined tumors are more aggressive. They have more risk of vascular invasion, so more metastasis, and they have high chance of recurrence. And exactly what happened in our patient, that we had early recurrence after 13 months of surgery, and actually
it was the first time evaluation, it was found at 13 months that the tumor was 6 centimeter. That means the tumor must have recurred quite early, but unfortunately it didn't came to ILBS, so was not detected early stage. So recurrence was quite early in this. And we also saw that the patient had quite widespread metastasis, lymph node, and even up to bones. So risk of SCC recurrence is there, and certain determinants we have already discussed, so I will not go into the detail of these things. And our patient had one of these risk factors like combined tumor, multiple tumor, and recurrence in 14 months. These are the factors which are predictive of early recurrence. Treatment. So patient was treated with gemcitabine and cisplatin. Dr. Chandan will be better to talk about the treatment, what was given. Yeah.
Can I ask you, was the recurrence biopsy?
Yeah, Dr. Chandan.
Okay.
In biopsy of the recurrence tumor was suggestive of combined hepatocholangiocarcinoma. So patient was treated with chemotherapy, gemcitabine and cisplatin along with the immunotherapy. There was a little bit mild range in AST, LT transaminase, so because of which there was a dose modification of immunosuppressive was done. Now coming to the treatment option, what should be the treatment?
How to treat this situation when we have a large tumor in liver, right lobe, 6 centimeter, and we have metastasis?
I think resection or transplant definitely are out. We should look for more systemic therapy, but as it is adenocarcinoma, some of them may be amenable to, as we said, gemcitabine and cisplatin, and not like HCC alone.
Exactly the same thing was given. Another important question is, when we are giving immunotherapy, then shall we consider to reduce the dose of immunosuppression, but that will bring in the risk of organ rejection. So we have to balance. We don't have any guideline as of now. And with the immunotherapy, the risk of organ rejection is something 30 to 40%. We have to weigh the balance, and probably we need more intense monitoring, and as soon as we see any evidence of organ rejection, then we have to probably step up our immunosuppression and delay or withhold the immunotherapy. Thank you.
Questions, comments, panelists, anything you want? Nothing? No. Okay, thank you then.
Thank you,
we'll go on to the next. Yeah, the next one, the HEPA scope is cancelled, so we'll go on to the next one. The liver quiz and carry home message. Akash Roy.
A very good afternoon to everybody. We'll rush through it because we're a little hard pressed for time, and the questions are quite easy. Anybody who's listened to all the 2-3 talks should be able to get it. Which of the following is not a prognostic risk scoring system for recurrent HCC? Do you have a voting system? And we wait 20 seconds for each answers. So we hardly have votes. Okay, so we move ahead to the answer. The answer is regain. Teaching point, we need to know these scoring systems that have been used for prediction of recurrence HCC. Regain is something it was just made up. Next question, which of the following criteria does not consider PIVKA2 as a component? Can we go to the poll? 20 seconds. So there's a mixed bag coming out here. The answer to this is the Tokyo criteria. All the others do consider PIVKA2 as a constituent. Number 3, identify the incorrect statement among the following. HCC MEL score includes AFP, Moral score includes NLR. Metro ticket 2.0 was based upon viral hepatitis cohort. Retreat score was derived from a majority cohort of alcohol-related HCC. Okay, again, we have got a mixed bag of answers. It's moving. So, okay. So we go to the correct answer is that retreat score was derived from, this is an incorrect statement. It's important to understand that most of these scores were originally derived of viral hepatitis cohorts. We do not have robust data both for NAFL cohorts as well as alcohol cohorts, and these are areas which need to be looked at. The last question, which of the following is a correct statement in the context of HCC recurrence? Retreat score consists of AFP at LT at transplant. Lower IGF levels has been linked to better survival. The beneficial effects of sirolimus in silver trial was not influenced by timing and AFP levels. Moral AI is a recently based artificial intelligence score which includes alpha fetoprotein but not PIVCA. Important is you need to address the correct statement. So there are different sorts of answers. I think the one that was marked least is the correct answer, that retreat score does consider AFP at liver transplant. Lower IGF-1 has been linked to poorer survival. The beneficial effects of silver trial, as already alluded to, was dependent on subgroup analysis on both time from recurrence as well as alpha fetoprotein levels. Moral AI includes both PIVCA and alpha fetoprotein. One for the audience. Can we just have a link among this? The link is obvious. I want someone from the audience to explain the link. We have 50 seconds for it. Can somebody explain? Number one, name the link and then explain the dots to connect all this. If anybody from Calcutta, it should be easy. Anybody? So somebody said metro ticket. I want somebody to explain the four pictures. No one? The answer is correct. The answer is metro ticket, but, and so how does these relate? Top left side is an Indian movie called Shanghai. Shanghai has the world's one of the largest and fastest metros. On the right hand side, you have a ticket, a metro ticket from Calcutta Metro, which is the oldest metro of India. On left lower down is the RA Forest, where the controversy in Mumbai is about the metro ticket, metro rail construction. And last is AC Milan from Milan, Vincent Mazzaferro, metro ticket 1, metro ticket 2, as well as Milan criteria. With that, we move ahead to our summarization for the two entities that has been discussed. For recurrent HCC on the left-hand side, we need to consider the primary modality. What was the primary modality, whether it's resection, ablation, or catheter-based therapies? Because your assessment would depend upon that. You need to assess the response and surveillance protocol for them. Number one point, when the recurrences occurred, do we have extrahepatic disease? If it is yes, again, as was mentioned before, that we have a validation of the BCLC cohort in this extrapolation. So you go, it goes somewhere similar to the BCLC cohort. I've tried to put some dots in here and there. If you've got preserved liver function, you are candidates for systemic therapy, loco-regionals as well as combination. No, you see whether it's a single lesion. Single lesion, you assess whether there's a candidacy for surgery or not. If yes, resection or LT, what's important out here is that resection has been suggested that if your recurrence after resection, if your primary modality was resection, is within 1 year, it's possibly better to go for an ablative procedure. Otherwise, you can even consider resection as we had discussed. If there is, then it is not a single lesion, you again go to the BCLC algorithms, decide whether there is PVT or not, decide whether you're going to bridge to transplant or downstage to transplant. On the other hand, on the left-hand side, if you have a recurrent HCC, number one, you have prediction models, Metro Ticket 2.0, retreat, Morale AI. You need to surveillance, different consensus. They say 3 to 6 months with cross-sectional imaging. The immunosuppression protocols need to be streamlined, minimize CNI, increase mTOR, stage the recurrence, decide whether it's a disseminated disease or it's an oligorecurrence. And if it's an oligorecurrence, whether it's intrahepatic or extrahepatic. Intrahepatic single site, whether it's again resectable, it can be ablated or resected. If it is multiple, again local regional therapies. Extrahepatic, it would fall into non-resectable options, and as already mentioned, for disseminated disease, the prognosis is dismal, and we have to balance the triple or quadruple equipoise. Thank you, everybody.
I have one question to you. Would you consider transplant again after a recurrence, after a transplant, a second transplant, if it fulfills criteria for transplant?
The liver is normal, and again, it's a normal liver with a recurrent HCC.
Yeah, within say Milan.
No, if it has not been addressed in literature, I think there may be case reports.
We don't know. Okay.
I think, yeah, we have one question. Yeah.
Do you have an age limit for be candidate for liver transplantation in India?
In India, since it's LDLT predominant, there is no definitive age limit. In the DDLT program, there are state-wise cutoffs. There are not definitive limits. We have debated upon this, that whether the physiological function should be compared against the chronological function, but it is a very important determinant which would influence your recurrence rates as specifically with HCC is concerned.
So we look at the physiological age, and I mean, at our center, we have transplanted as high as 78, 79. There are very few, but yeah, because that mostly it will be around early 70s. Okay, Akash, I think you're a very tough quiz master, but it was very well done. Yeah.
Thank you, sir.
I think we'll close this session, and thank you all the speakers, moderators, and my fellow co-chairs.
Thank you, chairpersons and moderators and speakers for the wonderful session. Now, those who wants to have a coffee or refreshments, it is being served outside. Now, beginning with the 7th session, managing a case of HCC with metastasis and progressive disease. I would like to invite the chairpersons, Dr. Chandan Guha, Department of Radiation Oncology, Albert Einstein College of Medicine, New York, and Dr. Rohit Mehtani, Department of Hepatology, Amrita Hospital, Faridabad. And the moderator of the session, Dr. Pankaj Puri, Department of Gastroenterology and Hepatology, Fortis Hospital, New Delhi. Dr. Mithun Sharma, Department of Hepatology and Gastroenterology, AIG Hospital, Hyderabad. And Dr. Abhay Kapoor, Consultant Radiology, Rajiv Gandhi Cancer Hospital, New Delhi. I request all the chairpersons and moderator to take their seats and begin the session.
Good evening, everyone. I would like to call on stage Dr. Fabio Piscaglia from the Division of Internal Medicine, Hepatobiliary and Immunoallergic Diseases from University de Bologna, Italy, to speak on the topic managing a case of HCC with metastasis and progressive disease.
First of all, I would like to thank Professor Sarin and all the entire organizing committee for this kind invitation. It's a big pleasure for me to be here today, and also for assigning me this challenging topic that I found very interesting. These are my conflicts of interest. We are speaking about patients with advanced stage because this is defined by extra hepatic spread. And according to the guidelines, there should be no such lecture today because only systemic treatment is recommended. Is extrahepatic spread metastasis a relevant prognostic factor? Yes, it is. In case of progression, the post-progression survival of patients receiving sorafenib, so when they come out progressing under sorafenib, it is worse when there are new extrahepatic metastases, as you can see here, compared to progression of local disease or occurrence of new intrahepatic lesions. And this is confirmed, even though this is usually combined with vascular invasion, so it may be difficult to dissect the role of extrahepatic metastases. As you can see here, they are together. In order to try to gain some deeper information on this, I outlined the role of metastasis and extrahepatic spread in this phase 3 trial, which is second-line treatment with regorafenib after sorafenib. As you can see here, the prognosis of patients with or without vascular invasion under regorafenib was similar, whereas patients with extrahepatic disease had a worse outcome than patients with placebo if they were not taking regorafenib. And this is confirmed by the combination of macrovascular invasion and extrahepatic spread together. So this defines the extrahepatic spread, but we see that from this graph, people with only extrahepatic spread are more in need of an effective treatment because they do worse if we do not treat this condition. So if this systemic treatment is the standard of care in advanced HCC with extrahepatic spread, why are we discussing its management? Why was I asked to deliver this talk today? We should simply recommend systemic treatment for every patient, isn't it? However, we know that in the absence of randomized phase 3 trials in this specific setting, early clinical studies show improved survival when radical local therapy is added to standard systemic therapy for oligometastatic disease. However, no biomarker for the identification of patients with the definition of oligometastatic disease is clinically available. So the diagnosis of this condition, which is a sort of intermediate condition between advanced metastatic disease and absence of extrahepatic spread, today is based solely on imaging findings. This is what is recommended by this paper of a consensus conference. Sorry, I'm pushing the wrong button. Okay, what is oligometastatic disease? This recommendation of the European Society of Radiotherapy and Oncology and the European Organization for Research and Treatment of Cancer, I think, well summarized different possibilities. As you can see on this column, column A, this is de novo oligometastatic disease. So you have cured, this refers to lung cancer, but you can apply it to liver cancer. So you have cured the initial tumor, and then, or you have seen the initial tumor, and at the same time, you have also few and little metastatic disease. Or you might have metachronous oligorecurrence, so at the same time, you detect at a certain point metastases which are few in number and in the same organ, and usually after 6 months of treatment of the initial tumor. either under or without treatment, or metachronous oligoprogression. So you have progression under treatment, but these are few lesions. Or you might have repeat oligorecurrence, which is this middle column, in which after local treatment or systemic treatment, you have you have a new lesion, cured some other lesions, and you have progression or only one lesion. So this is a bit worse, in my impression, than the de novo oligometastatic disease, or repeat oligoprogression, or we could also have induced oligometastatic disease. So you start from many metastatic lesions which under systemic treatment are reduced to only few ones, many disappear. So to summarize, we have three different situations: the de novo oligometastatic condition, the repeat oligometastatic condition, and the induced oligometastatic condition in progression of severity. So how we can detect the extrahepatic spread? FDG PET with CT is a very sensitive technique, better than PET, and we have to aim to detect the location of metastasis, which by frequency is most commonly in the lung, regional lymph nodes, and bone, more rarely in adrenal glands or in the abdomen. Please keep in mind, because these are usually the site where we see these lesions. Brain is rare, so do we need head CT? No, on a regular basis, only if brain metastases are clinically suspected, for instance, in case of headache, nausea, or motor weakness. And we have no information about these patients, how they behave, because these patients are excluded from clinical trials. PET-CT might be important to, in my opinion, to confirm that this is only oligometastatic disease. We are not missing additional instances, but is not performed as a rule to detect any extrahepatic spread. So we have to keep in mind that oncological therapy have to prolong survival with good satisfactory quality of life. So I tried to go back to my experience in my clinic and see different scenarios in which we can apply treatment of extrahepatic spread. The first scenario is in case of early and or polymetastatic disease with no metastasis creating any dominating local symptoms. This patient is to go with systemic treatment only, the one providing longest survival regardless of objective response. If instead, in the second condition, one metastasis is causing a dominating local symptoms, pain from a bone uncontrollable with painkiller or other things like this, then we have to use the treatment, systemic treatment, which provides a good objective response, because the decrease in size of the symptomatic metastasis could help to alleviate the pain. And this can be combined with local regional therapy as a palliative care. If we have metastasis with life-threatening location, then yes, we have to start systemic treatment, but this usually takes time to reduce the lesion. Therefore, we must also apply local regional therapy, which has to be the most effective, as it may impact on overall survival. Then we have the three different oligometastatic conditions. In case of de novo, so few metastases, maybe at least 6 months after curing the initial tumor, we can wait to start systemic treatment if the local regional therapy have the possibility to cure all these lesions, because these may impact on overall survival. If instead it is a repeat oligometastatic disease, we have to consider to go with systemic treatment, maybe together with local regional therapy, but only if effective and safe, that do not worsen liver function. And in case of oligometastatic disease induced, we may continue the ongoing treatment and add on the local regional therapy only if safe and radical. So these are some article appearance defining this local general therapy. If we would like to summarize the treatment of extrahepatic spread beyond systemic treatment is the treatment of pain with painkillers. Simply try to avoid non-steroidal anti-inflammatory drugs because of the toxicity for the liver and the kidney. Treatment of bone metastases with external radiotherapy or embolization because of pain or because of location at risk of spontaneous secondary fracture, of causing neuropathic pain, neurological symptoms. And this is done by radiation, as you can see in this paragraph. We may use, as mentioned, external radiotherapy, even extraskeletal if it is causing pain. We might use surgery for late de novo, oligo, or preferably single metastatic disease, peripheral lung metastasis, musculoskeletal causing pain, isolated single intra-abdominal metastasis after months or years after curing the initial tumor, or for life-threatening location, for instance, the backbone. Or we can use even arterial embolization for bone metastasis or for monolateral adrenal mets. Additionally, for the lung, we may use percutaneous radiofrequency ablation, which works better if there are a few metastases less than 3, small, less than 3 centimeters, with alpha-fetoprotein less than 400. Therefore, to conclude, as carry-on message, when we approach patients with extrahepatic spread, we have to define whether the patient has localized tumor metastasis-related symptoms or is asymptomatic. In case of symptoms, if these can't be sufficiently controlled with medical therapy, or whether metastasis is located in life-threatening position. By imaging, we can define whether there is oligometastatic disease, verifying timing of onset, number and rate of progression of metastasis in connection with previous, never, or ongoing therapies. But my recommendation is to discuss all these situations in a multidisciplinary board, either as palliative or curative options. And then if we propose the treatment, local treatment of extrahepatic disease, this has to be discussed with the patient and the family, discussing the possible treatment options, at where we have several lines of therapy, and always aim at maintaining the best quality of life for the patient, together with prolonging overall survival, and the priorities have to be shared with the patient. Thank you very much for your attention, and if you are interested in ultrasound, next year in Italy we have the European Congress Ultrasound.
Thank you, Professor Fabio. We can take one question from the audience.
Yeah, I have one practical question. Thank you for your talk. You have metastasis, you treat with systemic treatment, and you induce oligometastasis, and after you do a locoregional treatment, you have no more metastasis. Do you continue the systemic treatment?
Yes, we do. Yeah. Because the risk of, at least for some years. Then what happens after some years, especially with immunotherapy, we don't know. But we only temporarily suspend systemic treatment only to make safer the locoregional treatment.
Yeah. Even with tyrosine kinase inhibitors?
Pardon?
TKI.
TKI?
Also, you continue TKI also?
If the patient is responding and the
so
progression is limited, usually this should be defined as progressive disease. So if there is an opportunity of a effective second-line option, we may continue treatment but change the drug. But we will not stop any treatment even if we cure the lesion.
If there are no... yes.
Very brief question. When do you call resistance to a given immunocheckpoint inhibitor? For example, there are clusters of cells which develop after nivolumab or after atezolizumab. So when do you say it is resistance, and how do you read it out in your oligometastasis or others?
Primary resistance is defined by progressive disease at the first assessment. Then usually patients tend to be stable or have an objective response, but at a certain point, as you mentioned, some lesions may progress individually. In these cases, discussing case by case, this is resistance, but if it is still limited and can be either ablated or resected, we proceed with combining the resection, but it has to be 1-2 lesions in the same organ. If it is in different organs, then we consider a failure.
Thank you, sir. For the next talk, I would like to call Professor Peter Gay from Department of Internal Medicine, Germany, University of Medicine, Germany. The topic is refractoriness to loco-regional therapies. What's next?
Yeah, good afternoon from my point. I provided a video. I think for the quality of the presentation, I would prefer that you present the video, and I will be available for discussion afterwards. And by the way, thank you very much for the kind opportunity to participate in this meeting.
Can we have the presentation? It's a video presentation you'll have to play. Is it a presentation or a video?
Well, you have it as a video. This is the PowerPoint presentation, but I recorded a video.
Sir, if possible, can we play the presentation and you present?
So you don't have the video?
No, sir, we don't have the video.
In this case, I suggest that I share my screen, and we hope for a good quality.
Yes, sir.
Can you see my screen? Can you see my screen?
Yes.
Yeah, I've been giving the task to talk about refractoriness to loco-regional therapy, what is coming next. These are my disclosures. I will refer, with respect to loco-regional therapy, mostly to intermediate stage disease, and here in this setting to transarterial chemoembolization, although various other loco-regional modalities exist. This is a typical case which is considered to be multinodular disease, arterial hyperenhancement, by definition no intravascular presence and no extrahepatic metastasis, but non-resectable. It has become relatively broad what is to be offered today in that situation. Initially, for intermediate stage, there was only TACE, and if this was progressive disease, either not feasible because of toxicity or failure of therapy, refractoriness, systemic therapy. So the easy answer to the question, what's next is systemic therapy. But in clinical reality, the situation is certainly far more complex, and I would like to dive into transarterial chemotherapy first. It has been proven in 2 decades ago that chemoembolization is improving life compared to controls, and that had been fostered by additional meta-analysis. The outcome is quite variable, and this is one of the issues which makes it sort of difficult to compare. If you look at the outcomes here in different trials, you see that it starts with times with only 26% of 3-year survival going to 66%. So that is a strong indication that differences in patient selection contribute to the outcome. An alternative to TACE might be SEERT. This is from my institution, where we compared SEERT and TACE concerning here progression-free survival and also overall survival, and saw a comparable outcome for these 2 modalities. It can be in reality more complex, and sometimes different local regional therapies are combined. Just to highlight this recent trial where actually in combination with sorafenib, TACE and TACE plus followed RFA have been compared with a favorable outcome. So local regional therapy, of course, needs to be defined, and in clinical reality, it's definitely more than TACE. And in addition, for intermediate stage disease, there's currently a strong set of trials ongoing where local regional therapy is compared with local regional therapy plus systemic therapy, or as we are doing it, compared with TACE, systemic therapy with TACE. There will be quite a large number of trials in the future adding data to this situation. I'd just like to highlight that TACE was defined at a time when systemic therapy was not available, and in that setting, we really need to define the role of systemic therapy in intermediate stage disease. I like to highlight the complexity of the situation by using a patient example. A 61-year-old male with hepatocellular carcinoma based on hepatitis B virus infection, good liver function, good performance status, by definition no extrahepatic spread, and we integrated this patient at that time into the Precision 5 protocol, DEP-TACE. And you can see here the patient before TACE and after first, second, and third TACE. And what you see here is actually quite common. There are areas where arterial hyperperfusion is maintained and necrotic areas. And this is not changing dramatically after second and after third TACE. So in summary, this patient is at best showing stable disease. And that was the case, in fact, although the embolization procedure was quite efficacious. You can see here the hypervascular nodule and the vascular shutoff as a result of TACE, but nevertheless not better than stable disease. And here we are coming to the standard recommendation, treatment stage migration, move to the right in the BCLC scheme. How do we define TACE failure, and when do we define TACE failure? This is the most important problem. Well, first of all, we need to appreciate that in the different assessment systems, partial response may be defined differently, 30% decrease, 50% disease. However, in summary, what we want to see as a result of TACE is either complete response or partial response, and would not consider stable disease a valuable answer. And this is a difference which needs to be acknowledged. Systemic therapy defines stable disease as control. This is by definition, or by, let's say, general agreement, not the case for TACE. This is one of the major differences. So when do we define? It had been debated in the past whether you do a first TACE as an assessment and then decide whether there is a response or non-response, or whether you do it twice. There are some data, and Masatoshi Kudo had been suggesting that the definition of refractoriness should come from more than 2 incomplete necrosis, appearance of new lesions, appearance of vascular invasion or extrahepatic spread. By definition, then we would switch into advanced stage disease or strong tumor marker increase. That we do it twice is based on several trials. I'm highlighting one here, where initial response to TACE was seen in 50% of the patient after first TACE, and concerning these non-responders, in a second TACE, again 47, almost half, showed a significant response. This is one of the reasons why we recommend to do TACE twice before you decide about the effectiveness of therapy. You should be aware that the outcome is not as good as maybe hoped. In several trials, the efficacy rate, the response rate was in the range of 30 to 50%. So a relatively large proportion of the patients will fail to TACE therapy. What is the outcome in these patients? And we can use data which have been defined based on an exploratory analysis on the IMbrave150 data. In this group of patients, we were able to compare patients which had no local regional therapy, 1 or 2 procedures, and more than 3 with respect to overall survival outcome. And what we saw was that the overall survival outcome was much better for those patients either never receiving TACE or up to 2 TACE, but it got worse when 3 or more procedures were performed. So another argument to have these 2 procedures and then to decide whether you switch or not. Same was actually true for the odds ratio for patients with respect to objective responses. Very good odds ratio for patients with 1 or 2 procedures, and then getting worse in patients with 3 procedures or more. And in general, to highlight this again, we have to discuss the alternative of systemic therapy, and this is again from the IMbrave150 trial. In patients where we saw no extrahepatic spread or microvascular invasion, so a small cohort which would typically be considered to be traceable, again, a very good outcome, 24.6 months for atezolizumab, bevacizumab treated patients, much better than the all-comer outcome of 19 months. So systemic therapy in some patients may be an alternative. Last but not least, I'd like to highlight one particular trial, and this is the ABC HCC trial, which compares atezolizumab, bevacizumab in the subgroup of patients with intermediate stage disease with TACE. We are in a situation where we now have included almost 100 patients. We want to go for more than 400, and this will be one of the trials where we get the answer, what is the role of TACE precisely versus systemic therapy in intermediate stage disease. The way to decide is actually quite pragmatic and is reflecting real life. If you start with systemic treatment, we go for response. If the response is acceptable, either complete, partial, or stable disease, we continue and decide again. If there's progressive disease, you may continue beyond progression, but this depends on the definition whether it's clinically useful or not. And in this arm, in the TACE arm, we actually do precisely what would be the answer to your question, when what to do in refractory situations. Patient with TACE showing complete response, watch and wait. Partial response, decide whether you want to do it again and complete it. And if there is stable disease, by definition, we would say that's not enough. And we ask the question, is the patient TACEable? And does it make sense? Is it very well reachable, the tumor, or not? And then you can decide whether you go ahead with TACE or you decide that this is time to failure of treatment strategy, the endpoint of our trial. A similar trial is actually the REPLACE trial. So in the end, Mr. Chairman, ladies and gentlemen, we have different local regional interventions, whether it's ablation or TACE. If this fails, we typically switch in the end to systemic therapy. It's not so easy as one might think when to switch and based on what measures, but it requires an intensive discussion, a repeated discussion in the multidisciplinary team to get to this information. Thank you for your kind attention.
Thank you, sir. To start the discussion, I have one question. So if there is a failure of TACE, then do you switch to a different loco-regional modality or directly go for a systemic treatment?
So in a situation where we have started with TACE and there might be an additional lesion which is well reachable within the liver, that might be considered to be improved by, for example, RFA or microwave. So that is a possibility. If there is clear-cut progression, for example, by bone metastasis, lung metastasis, we would certainly switch directly to systemic therapy.
Sir, I have a small question actually pertaining to the case which you had shown. The case was randomized as per the Precision 5, and it was the DEB TACE. So we called it refractory to TACE, but if we look at the actual life scenario, we do not randomize directly to DEB TACE or C-TACE. We actually look at the vascularity of the tumor, and in case it's very thin vascularity, we prefer doing a C-TACE. So instead of calling the tumor to be TACE refractory, maybe if on the first time, after the first TACE, if we had failed, we could convert it to C-TACE, and probably the results would have been better. But since this particular case is part of a study, probably that could not be done. But in real case scenario, I would like to shift to C-TACE for the second session.
Yeah, I mean, you're touching upon two important points. First is the difference between DEB TACE and C-TACE. We, for the most part, do C-TACE and do not see a particular benefit coming from DEB TACE. That's one thing. And the other thing, which is very important and typically neglected in all trials, the definition, or let's say the assessment, how well is the tumor reachable? Is there a nice feeding artery, easily and super selectively reachable by the interventional radiologist? This is, of course, making a difference. And in that setting, you might not have reached the end of what can be done interventionally. But in my example, I showed, and that's why I showed the perfect embolization with not perfect outcome, that sometimes, although you are technically sound, it's in the end not giving the result you want. That's real life.
Thank you, sir. I guess there's one more question from the audience.
Hello. Hi, Peter. So I just want to ask a hypothetical questions. Do you think in 5 years' time we are going to replace TACE with systemic therapy completely, or it is more likely we will combine TACE with systemic therapy?
Thank you, Thomas, for this important question from Hong Kong. You're touching upon an important point, and of course, what I believe is we have perfect patients for TACE. That will be a proportion of those TACE today, so not all, but some of them will remain and will be benefiting from TACE, but others, and they might be the more diffuse tumors, less well defined by arterial perfusion, that they will be having a better outcome by the systemic therapy. So I think the intermediate stage will be more clearly defined with respect to different modalities, but not a complete loss of TACE, no.
Agree. Thank you.
Peter, this is Shiv Sarin, and thank you for joining us. Would like to pose a question. You have a patient who has a near normal AFP of 10 and has a high PIVCA of say 200 and has portal vein thrombus, and you start him on atezolizumab and bevacizumab and has a tumor of about 3 centimeters. Now, how do you assess whether the treatment is effective, and how long would you continue to give your combination therapy?
Thank you, Shiv. The first question which crosses my mind is why did you got started with systemic therapy? Because you felt it was a vascular invasion. You were not precise with respect to what is taking place in the portal vein. Is it a tumor thrombus or is it
it's a tumor thrombus, and this case was presented in the afternoon somewhere, so that's why we did SBRT, but someone said let's start immunotherapy from the beginning, and the question was, do you give 6 dosages, 12 dosages, how long, in a rather non-inflamed tumor and tumor thrombus?
Yeah, I mean, we even in patients where we have a higher tumor burden and a good response, we have not yet the answer when to stop. Do you do a treatment pause or do you continue forever? And in your particular patient with a limited tumor burden, it's even worse because we do not have such a clear answer on the tumor response. For the time being, if the substance is available, I would be rather inclined to have a prolonged immunotherapeutic intervention, but this is not the case in all countries in the world, and then you have to make decisions.
Okay,
Not sure whether I really answered your question, Shiv, but I tried my best.
Thank you, Peter.
Thank you, sir, for the wonderful talk and discussion. We'll now move on to the next session, and I would like to call on stage Dr. Dinesh Jyotimani, Director, Department of Hepatology and Liver Transplantation from Rela Hospital, Chennai. Sir will be speaking on the topic of metastatic HCC with preserved liver function, treatment modalities, rationale and outcome.
First of all, thank you, Professor Sareen and Dr. Ashok Chaudhary, organizing team, for this wonderful meeting on an important topic. So we're going to talk about the metastatic HCC management with preserved liver function test and how we can go about it. I must say this topic has slight overlap with the first one, but we try to rationalize in a slightly different way. BCLC incorporated those with metastatic HCC, BCLC incorporated metastatic HCC into an advanced HCC classification. But we know that advanced HCC also has something with tumors with portal vein invasion, and we know they are not the same. Those with portal vein invasion have a different prognosis than those with metastatic disease. So that's why INSL in its recent publication reclassified or subclassified into C1 and C2, those with portal vein invasion and those with extrahepatic disease, that is metastatic disease. So we're just going to talk about the holistic management of the metastatic disease, what can be done about it. And these are the currently available multikinase inhibitors and immune checkpoint inhibitors for metastatic HCC. I'm not going to go into the details of that. So in fact, the first speaker said that there are different types of metastasis, oligo and polymetastasis. So therefore, all metastatic HCC are not the same. So some are oligometastatic, some are polymetastatic. And usually the metastasis goes into lungs, adrenal, and the bones. So somebody with HCC who are unresectable has an adrenal metastasis. As per the current existing guidelines, they straight away go into systemic therapy. But somebody who has a very preserved liver function test and who are young and who are otherwise good performance status, I think that's a little unfair on the treatment. We should be a little more aggressive on therapy. Is there an evidence for this? So yes. So if somebody has an HCC with an adrenal metastasis, a single lesion in the adrenal gland, if you manage them with a surgical approach, resect the primary tumor and resect the adrenal gland tumor, in comparison with sorafenib, they have a much better survival rates. 7.5 months with sorafenib therapy, which is more of BCLC current guidelines, the previous guidelines as well, compared to 28 months if you have an aggressive therapy. But these numbers are very small, 8 patients in each group. But what I would suggest is if we even add immunotherapy to this sort of aggressive therapy, your survival may even get better actually. So therefore, we cannot give up on somebody who has metastatic HCC just like that. Unfortunately, not every patient with HCC are candidates for resection, because many times you see very large tumors, inoperable, poor residual volume, and they may have a little bit more than one metastatic lung, like what you see here. The lung lesions may be more than one. So therefore, the surgical option is not here, not a treatment option here. So that's why we rely on local regional therapy. Now, if somebody has HCC like this, and they are not resectable, you have 3 lesions here. One is the liver, one is the lung, and one is the hematogenous. So for liver, we can do radiotherapy. For lung metastasis, if they are isolated, you can do RFA or even radiotherapy if it's feasible. And metastatic HCC is a systemic disease. Therefore, for hematogenous spread, you need to add immunotherapy. This may rationalize better than just putting them on immunotherapy. Now, is there evidence for this? Yes. But again, once again, these are small numbers, retrospective studies. So if you see in this trial, so those with advanced HCC were given TACE plus sorafenib, and the other group received TACE, sorafenib, and the immunotherapy. You could see the disease control rate was much higher, much better in the triple therapy regimen. The progression-free survival was much higher in the triple therapy regimen, and the overall survival was 23% in the triple therapy compared to 13%. So yes, so triple therapy, local regional therapy mixing with a combination of immunotherapy and sorafenib or other tyrosine kinase inhibitors may be a futuristic option. Now, adding local regional therapy to a immunotherapy or multikinase inhibitor, is this just an additive? No. There is a real effect of local regional therapy on the tumor microenvironment. What radiotherapy does or what TACE therapy does is, it creates an inflammatory milieu in the tumor microenvironment. It recruits more cytotoxic CD8 cells and natural killer cells, so that these cells act upon the tumor cells. So when you give immunotherapy after a local regional therapy, you have CD8 cells and the NK cells closer to the tumor. Therefore, the immunotherapy can act better. So these are the soldiers. When there is no soldier, you can't expect immunotherapy to work. Are there trials on this? Yes. Using tremelimumab followed by local regional therapy and continuing with tremelimumab shown to improve survival as well as improve intratumoral CD8 cells. Which tumor responds to local regional therapy? That's very important. Histologically, there are different varieties of HCC has been described. But those who have lymphocyte depleted HCC respond well to local regional therapy because, as I told you, local regional therapy recruits inflammatory cells. It converts a non-inflammatory HCC to an inflammatory HCC where your immunotherapy may work. So we are going to have a gamut of treatment modalities for HCC in the presence of immunotherapy, resection, local regional therapy, along with multikinase inhibitor, and all this combination. So it's going to be exciting next few years. Then who's the right candidate for such therapies? Certainly you need to have a very good preserved liver function test. Morning you heard that child A patients respond very well, non-cirrhotic patient of course, rather than child B or child C. And there may be multiple factors that may influence your treatment modality, particularly the combination therapy, whether they have single metastasis, multiple, your tumor biomarkers, HCC histology, and the intratumoral inflammatory activity. So all these factors may be taken into account, and therefore, if you need to treat HCC with this combination therapy, a biopsy may be warranted in these patients. So I finish with this last slide. It's actually a quiz, I was told, but this is what I want to finish. A 45-year-old gentleman with preserved sort of liver function test, left lobe HCC with an isolated adrenal metastasis. It's a metastatic HCC. You can do nothing, end of life care. Definitely we can't do that here. Sorafenib, lenvatinib may be an option, which is according to the current guidelines. or you can do TACE with lenvatinib, or if you want to be really sort of go and treat all these tumors individually, you can do a TACE, adrenal resection, followed by immunotherapy, etc. So you have a lot of options and opportunities here. Thank you. And in conclusion, HCC treatment is an evolving modality with combination therapy. And we need to identify this favorable metastatic HCC in a well-compensated patients where you can give a lot of other treatment options. What I would like to conclude is metastasis doesn't mean they are palliative. Thank you.
Thank you, sir. Thank you, sir. We can have 1 or 2 questions.
Yeah. Thank you for this excellent talk. I have one question because about the localization of extrahepatic metastasis. Do you know if the localization, lung, bone, adrenal, is associated with prognosis or with response to treatment? Because, for example, in renal cancer, it is well known that bone metastasis has a worse prognosis than other type of metastasis, and also respond less than in TKI when you have bone metastasis in renal cancer.
I would agree. I mean, see, that's why I said, like, we need to carefully choose these sort of patients. Say, for example, adrenal metastasis do better than your bone metastasis. So therefore, it may not be readily, we are going to use this combination therapy. It's the gist of what a future of HCC therapy will be encountering, because you may have a small spinal metastasis rather than a big pelvic metastasis. They may behave very differently in terms of the treatment approach. Yeah.
Thank you, Dr. Dinesh, for the wonderful talk. In fact, there is one small point which I would like to add, because you mentioned about SBRT for debulking. So, well, if you have a very large liver lesion and extrahepatic disease also, so probably giving SBRT for such a large lesion may be difficult for the radiotherapist, but Y90 can serve this purpose very well. And in fact, if you have an adrenal mets, the IR can tackle both the things, Y90 for the liver, and you can do ablation for the adrenal mets. Similar thing can be done even for the lung lesions. And then later on, we top up with the systemic therapy, maybe immunotherapy, to tackle with the hematological spread.
Yeah, absolutely. I mean, see, that's what I'm saying. We have a whole gamut of therapeutic opportunities for the future with the availability of immunotherapy. These things were not there till recently. So that's what I'm trying to say. Radiotherapy or even TAV, whichever we are comfortable with, I think we should go ahead with that.
One last question. This combination aggressive therapy looks very promising, very attractive, but once there is an extrahepatic spread, there is no good evidence today, and aggressive therapy, so much cost, so many adverse events, is it justified or it's a future?
I think, see, if you look at the current guidelines, metastatic disease equal to systemic therapy, even that is not justified, I would think, because there is a lot of things you can do. The number of lesion, the site of the lesion, and if they have somebody with young patient, young age group with a preserved liver function, and I think we should treat them aggressively. I don't see a reason why we should just put them on a palliative care and end of life treatment. Actually.
Thank you. It was a very good presentation. As you have told, there is a metastatic disease, no question of palliation. Right. Suppose it is a metastatic disease with a gross ascites, hypoalbuminemia, and there is other complication or decompensation. In this case, what you will do?
That's exactly what I said. So not everybody with metastatic disease will be a candidate for this sort of combination therapy. So they should have a very preserved liver function test. They should have no decompensation. They should have a good performance status. So only that sort of patients, very young, who's got good liver synthetic function, no hypoalbuminemia. Because if you're going to give radiotherapy followed by immunotherapy, the liver may fail actually, decompensate. You end up in trouble actually. So therefore, you need to choose very early cirrhotic patients, non-cirrhotic patients, that sort of age group.
Even if you have selected in child A cirrhosis and given this local regional therapy or systemic therapy, they further decompensated within few months. In this case, what you will do?
I think it's a learning curve for all of us actually. So yeah, we need to learn, so if they decompensate, there's no much answer.
Okay, thank you.
Thank you, Dr. Dinesh. We'll now move on to the next talk. The next talk is a case scenario.
Sorry, Rohit, we have a little bit of change in plan because Dr. Riyad Salem, he is scheduled to talk at 6:05 and we are running the session by late. So we request him to join virtually and so that we can conduct his talk, then we'll follow the rest of the things. So for this session, I request Professor Y.K. Chawla, sir can join in the dais. No, you please, you can carry on. Sir will be there. And Silpa, please connect. And Dr. Nityesh and Dr. Arun Kumar. So that is a little bit of puzzle because of the overlap of the situations.
So good evening, everyone. So we're looking forward to the next exciting state-of-art lecture, and this is on expanding the horizon for interventional radiology in HCC management. And to speak to us on this is Dr. Riyad Salem, who's Professor and Chief of Intervention Radiology, Northwestern Memorial Hospital in USA. Over to Dr. Riyad.
Just add to his introduction, so I have learned everything from radioembolization just because of the Riyad Salem, and also it is his presence that has made it someplace in BCLC classification. So he's a master in radioembolization.
I don't know, can you hear me? Can you hear me?
Yeah, yes, we can hear.
Wonderful. Thank you very much, and good morning. And I appreciate the kind words. And it's a pleasure to speak to you this morning. And thank you for changing the schedule a little bit, because I'm actually scheduled to speak in about 15 minutes at another meeting that actually I'm moderating. So I was just going to spend about 15 minutes or so really talking sort of as a big picture what is going on from an interventional radiology perspective. And obviously this has to do with combining with immunotherapies, and these are my disclosures. And actually, if you look at a very nice paper that Peter Galli published years ago, the discussion had to do with patients that are treated and the way HCC patients move through therapeutic algorithms. And the discussion of left to right and right to left always comes up in terms of how they stage migrate through the BCLC algorithm. And the idea is that you migrate to the right as things progress. But in fact, with better therapies, including local regional therapies, et cetera, you actually in fact migrate to the left as well. And in fact, if you look, a better representation is this network map that we put together several years ago about the way in which patients really move through the algorithm, and they can shuffle back and forth between local regional therapy and resection and radiotherapy and systemic therapy, et cetera. And in fact, the HCC algorithm is quite complex now, given the therapies that are available, and really was reflected by the previous speaker discussing how unique you can manage patients depending on clinical presentation. And I put this document together a few years ago with Tim Gretton for Journal of Hepatology on reviewing what we can do in interventional radiology in the era of immuno-oncology. And it really has to do with combination type treatments. I think that's not a mystery, and the fact that many of these treatments can now be performed safely really opens the door to capitalizing on strong, localized, very precise cytotoxic treatment, and then of course benefiting from the long-term benefits and duration of the immunotherapeutics that are available. And again, thank you for the kind words about radioembolization that is now part of the BCLC algorithm. Certainly there's tremendous data on radiation segmentectomy and other types of things in the early disease. We haven't been able to demonstrate superiority over systemic therapy in the more advanced setting, with the exception, I would say, of the Dosisphere study. But certainly there's a role now, and you can see how complex and nuanced things have become. But more importantly, the idea here is that the algorithm now adds clinical decision-making. And again, I would repeat that. I believe the prior discussion was nothing but clinical decision-making based on individual patient characteristics. And I think that's good, because algorithms certainly cannot be too dogmatic and too prescriptive when in fact we are trained and have an obligation to basically select patients and treat patients based on their individual characteristics. There are problems, though. I mean, when you think about where we are with local regional therapies and systemic therapies, is a lot of patients go untreated. The lack of recognition of options is one. The lack of recognition of understanding HCC, the idea that maybe HCC do very poorly and there's no point in treating, that's just not true. And we certainly learned that from the work from the BCLC group over 30 years. And so there are still a lot of patients that do not get treated. And a lot of patients, even with very early disease, don't even get any consideration of resection or local regional therapies, et cetera. So there still is a lot of work to be done. And the idea and the theme, and again, I think was reflective of the prior presentation, is based on working together. And there's a lot of data that shows that if you work together and you have the expertise of every subspecialty at your tumor board, then patients do better. You have the experts there, you can really individualize care. What do modern studies show? What is contemporary data, evidence, what does it support? So I think it's really something to think about. And again, this was reflected in the prior discussions. But the exciting component really is combining now with these tremendous results that we are seeing with the immunotherapies. And the idea of combining local regional therapies, with systemic therapy is really something to be considered. And there is a rationale for that. One, of course, is when you think about the places where there's still some areas to grow as intermediate stage HCC, being very heterogeneous, and the new algorithm certainly tries to improve on that. Certainly the efficacy of local regional therapies is impacted in some form by tumor burden, but you also want to be cognizant of being able to transfer and transition a patient to systemic therapy when they are undergoing local regional therapy. And one of the challenges I would say, however, is when you think about the level 1 evidence and the level 1 studies, the granularity, the tumor granularity is still missing. And again, this was reflected in the prior discussion about the large tumor, the small tumor, the multifocality. That would be my one area of a challenge, in that we need more of the tumor burden and the tumor disease granularity when it comes to a lot of these large clinical trials. And I think that's very important. And when you combine these types of therapies, then again, you are able to convert patients from right to left and left to right, and again, as a network, and cure patients that are otherwise incurable. There's been some work in combining local regional therapies with TKIs, and none of those really have moved the field forward. A lot of them have been attempted, as you can see here, and really the only one that really moves anything forward, although I'm not sure completely implemented, is the TACTICS trial, improving PFS and sort of time to subsequent treatment and these sorts of things. But there certainly has been a lot of work that is on this, and I think this needs to continue. But times are exciting because there are a lot of studies that are ongoing now with immunotherapy agents and local regional therapies in the form of TACE and radioembolization, as mentioned before. So there are a lot of studies that are ongoing, and hopefully these will continue to move the field forward, because certainly systemic therapies don't answer all the questions, local therapies don't answer all the questions, and we are now seeing more and more patients responding very well on systemic therapy, but having tumor breakthroughs here and there, 1 lesion, 2 lesions progressing, despite the rest of the body being stable and having tumor control, that we are now applying local regional therapies in there in whatever form, so that we can maintain those patients on the systemic therapies, given how well they are tolerating them. And you can see from this graphic here that basically the local regional therapies in general are more dominant early on, but as you expand, there's lower and lower role, although the launch trial that I'll mention in a second may challenge that a little bit. And of course, there are some patients in the earlier disease, in the early BCLC, that also don't do very well, that may be considered for systemic therapy. Again, that data needs to be forthcoming, but there is some rationale to that, because certainly there are bad Ds, as we call them, that systemic therapy might be something to consider. Now, of course, we are all seeking to find this quote, and again, this was, I think, shown in a prior slide. Can we increase immunogenicity of these tumors with local regional therapies of whatever form, radiotherapy, cryoablation, embolization, et cetera, and when would that be done? And so there certainly has been some work, and this is Tim Gretton's work from NIH that shows that this effect clearly happens, but what is the clinical applicability of this? And certainly the abscopal effect is something that we all try to seek, and I don't know how frequently we see it, but it's something that we are all sort of opening our eyes to, given the fact that these immunotherapies are responding so well. There is some work being done now combining durva-bev and chemoembolization, and this is the EMERALD-1 trial. I suspect data will be forthcoming in the next year or so. So again, there is a recognition that we need to augment the effect of the local therapy with systemic therapies, given how well they are doing and how well tolerated they are. And Emerald 3, also with chemoembolization as the gold standard, and then adding systemic therapy to that agent to see what effect that will have. The other issue, of course, is the effective transitions from systemic therapy, from local therapy to systemic therapy, and when does that happen? And there are many ways to think about that. And again, these are sort of theoretical, and this is Dr. Kudo's diagram, where if you have low disease burden, you perform multiple LRTs, and then you define a taste failure and refractoriness, which can be very challenging, and frankly, in multiple guidelines is defined very differently. Or if there's intermediate stage with sort of high tumor burden, should that person receive systemic therapy first, and then quote downstage, and then receive local regional therapy? Again, I think there are some theoretical rationale to all of that. I'm not sure all of that is evidence based, but certainly this sparks the discussion when it comes to that. An interesting trial was a launch trial where the addition of chemoembolization, a local therapy to patients with advanced HCC, was actually able to improve overall survival. So these patients had PVT. They had tumors up to 10 centimeters in size, and the primary endpoint was overall survival. And I think surprising to many of us, this was a positive trial. So even in advanced patients, it's possible to influence overall survival. And this was basically, I believe, the only study that shows this kind of effect, but certainly thought-provoking that is there now a role for a local therapy, even in the presence of metastases? And again, I think the prior speaker said almost the exact same thing. Now, a couple of things I want to show you that are quite interesting that we have experienced. And again, I'm very grateful about the kind words about radioembolization in India. This was a patient that I treated. Hopefully you can see my screen here, but had multifocal right lobe, left lobe disease that we wanted to, in the era of nivolumab and the excitement of nivolumab, sort of maybe prime the immune system and with radioembolization. So we radioembolized this left lobe lesion here. We did not touch anything else. All of these other lesions were untouched. This retrorenal metastasis was untouched, but was radioembolized and started on nivolumab, and this is the follow-up scan. So a CR all across the liver, and the metastasis here posteriorly also disappeared. So an excellent result. And so again, primes us to continue expand these two. Now, certainly response rate, I just want to spend 1 second talking about response rate, because I think there is certainly still excitement over response rate. Talk about the rationale as to why that makes sense. And I want to talk about a hypothetical example here, that if you have a patient that is exposed to 3 potential treatments, one that gives you stable disease, one that gives you minor response, one that gives you a major response, and then all 3 treatments have the same mathematical TTP or PFS, so they all progress at the same time, because as you know, that PFS is from the maximum response. Well, if you are a believer in the lethal tumor load theory, that is, a certain amount of disease in the liver will cause lethality, then the person with the best response is furthest away from this lethal tumor load. So debulking and making lesions smaller, I think, is an important component, and treatments that do that is going to be an important part of future types of treatments. There is some work that's been done already when it comes to combining local therapies and immunotherapies, all preliminary. This is a retrospective study showing some partial responses in patients that have been treated with local therapy in this form Y90 and immunotherapy. And this series here from Sinai. So one was from NYU, one was from Sinai, basically showing that nivolumab is relatively safe in this patient population and can be considered. But interestingly, 2 prospective studies that were just published, the SOLID trial and the NASIR trial by Bruno Sangro, again, combining local therapy and immunotherapy. And I do think that this is going to represent sort of a framework for future clinical trials. So the BCLC algorithm now, as I mentioned before, now has local therapy here and allows you to stage migrate based on experience and skill set. And I think that was managed, that was discussed as well. And of course, now the complexity of the systemic treatments continues to increase. And again, patients, I think, are going to fluctuate back and forth, left to right, up and down when it comes to these treatments. And I think, again, interestingly, the intermediate stage now, we were able to stratify into 3 categories, which I do think is an advancement for that patient population. So again, as I mentioned, as I close off for my limited time, working together as a collaborative team is going to basically improve overall survival, and really is the best care. And I think it's our obligation as clinicians to work together and to make sure that we are able to provide the best care for that patient depending on the skill set that we have and the expertise that we have at that set. And again, that HCC patient series and lifespan is very dynamic and is based on an acceptance and a recognition of all of the data. And again, I do think the multidisciplinary management is going to continue to expand. And exciting for me as an interventional radiologist is now this combinatorial work that's going on, that's being validated, and most importantly, has been shown to be safe now. So now we have to get to the effectiveness component. Thank you very much for your attention.
Thank you, Professor Salem, for an excellent talk in taking us through the role of combination therapies and a multidisciplinary approach. Since this is a state-of-art lecture, there would be no questions. Just one point which I wanted to highlight was, you didn't mention about the different loco-regional therapies. Like if you have TACE, what is the role of ablation in those group of patients? Radioembolization and other ablative therapies. Maybe just...
Yeah, I mean, you're right, I did not do that. That was by design. This would be a much longer discussion, and given the limitation I had, I sort of thought that to keep it at a high level. I did mention TACE, I did mention Y90. The paper from Tim Gretton was based on ablation. So I superficially mentioned all of them, and there's no doubt that the nuance as to what to pick based on the disease characteristics will vary. So unfortunately, I was not able to address that in more detail. But certainly you are right. That requires a separate discussion, and that's where the localized skill set matters.
Thank you very much, and we appreciate your talk. Great.
Thank you.
Okay.
Thank you.
We'll move back to session 7 now. I'd like to call Dr. Cosmas Lesmana, Associate Professor, Department of Internal Medicine, Hepatobiliary Division from Indonesia. And sir will present a case scenario.
Yeah. Thank you, Mr. Chairman. Good evening, dear colleagues, ladies and gentlemen. So first of all, I would like to thank Professor Sarin, Dr. Manoj, and Dr. Asok, and all the organizing committee who invite me to be involved in this case scenario and discussion. So before I continue and we start our discussion, so I think Dr. Akhil will present one case from the ILBS. Please, Dr. Akhil.
Good evening, everyone. My case for today is a 61-year-old male patient who is a known diabetic with a BMI of 30 kg per meter square, who had an index presentation in 2010 in the form of varicose bleed. Before that, he was diagnosed to have a CLD, HCV, who got treated with interferon and had attained SVR. In coming to us in November 2021 with a HCC in the segment 6 and 7, for which he had underwent a TACE. And after a month after this treatment, we found a new lesion in the segment 4A, for which he underwent MWA. Further course of the disease, after a span of around 2 months, the previously treated lesions with TACE and MWA, they had an enhancement, so he once again underwent microwave ablation for the same. In April 2022, there were new lesions in segment 5, 6 and 7, and along with that the previously treated lesion in segment 4A had a residual disease, and along with it there was PVTT, there was right posterior portal venous tumor thrombus, for which he underwent SBRT, both to the primary as well as the tumor thrombus. Along with that he was started on TKI, lenvatinib. In October 2022, he had this still on SBRT, the segment 4A lesion was residual, and there was conversion from lenvatinib to regorafenib second line, because there was, despite of starting lenvatinib, there was serial rise in the AFP. In June 2023, when he came, he had a lung mets with 3 nodules within the lung, and this 4A, which was a residual disease, was treated with TACE. For the lung mets, he was treated with SBRT. There was a conversion from regorafenib to cabozantinib because of one thing, the AFP was in rising trend, and there was a pyogenic granuloma for which he underwent an excision. Now, when he had a last follow-up in September 2023, he had the segment 4A lesion, still a residual disease. Although previous lung mets were treated with SBRT, he had a new lung mets. This is the investigation wise. You can see from right to left, there is increase in AFP levels. This 4,773 was the one after the treatment with SBRT it decreased, but it keeps after that it was increasing, and serially the puca was also increasing. Regarding the imaging, one can see that there is a arterial enhancing lesion in the segment 4A. In the due course of timeline, this lesion persisted. Here you can see that there is in October 2022, there was a new lung lesion also. And but this segment 4A lesion was always a residual disease. The tumor size as of latest scan in September 2023 was about 11.5 centimeter, and previously treated tumor thrombus had recurred. So our working diagnosis was a patient was of course cirrhotic with superadded component of MAFLD because he's a diabetic and obese, with a portal hypertension, non-bleeder, non-bendable varices, bleeder, non-bendable varices with the HCC which is TKI resistant, of course progressive and metastatic. That we can see that in segment 4A with the performance scale of 0, BCLCC with AFP of 2000, PUCA of 870, with CTP 6A, with comorbidities of diabetes and obesity. With the treatment after September 2023, we started him on immunotherapy, atezolizumab and bevacizumab. Till now, he's under our follow-up. He has received 2 doses of immunotherapy. I would like to.
Okay, thank you, Dr. Akil. So I think what Dr. Akil has shown in the previous complex case, I think there's if we look at this Asia Pacific Clinical Practice Guideline on the HCC, that we know that we used to just follow sequential, the step-by-step that when we try to see whether that about the tumor size, the tumor number, and then again the microvascular invasion, whether this tumor will be resectability or not. But if we look here that in this algorithm, that so we look here that in the child pool A, B, and then whether this in this patient, whether if the patient is not resectable, so then we try to see that whether it can be started with the TACE or the systemic treatment. And then we know that based on our data, I won't go any detail on many data or evidence, because we know that also that all previous speakers have shown that about the data about the systemic treatment and also the local regional treatment, that this time the lenvatinib, I think, is the first line that is oral systemic treatment that have been become a first line treatment. However, that if we look also in the BCLC strategy, that looking at the systemic treatment, that nowadays that the first line that's now changed into the immunotherapy era. And however, when you look at it's always in the intermediate stage and also followed by the advanced stage. That in the case that Dr. Akil presented, that we have to see that sometimes whether we need to start earlier the systemic treatment or immunotherapy in a combination with the local regional treatment to prevent the progression. And this slide also shows the management of HCC based on the current expert opinion and recommendation in the World Congress on Gastrointestinal Cancer Barcelona 2022, whether they divided between the no contraindication to immunotherapy, and then if you can see here the first line, second line, and then third line until fourth line. Also, if there's a contraindication to immunotherapy, then we can start also the oral systemic treatment. And if there's a resistance, then we can change to other oral systemic treatment. So I will start with the discussion that this one question that might be not a very practical question, but I think this is important because since morning that it has been discussed about the role of pathology, the biopsy, the liquid biopsy, and then how we can identify better about the tumor characteristic and the tumor aggressiveness. So which of the following mechanism can lead to TKI resistance in HCC by promoting cancer stem cell-like properties? So I think look like these four options. So any maybe comment from the panelists, the moderators, chairman, or any other audience, I think about this issue, the questions. No. In my opinion, maybe the first one might be important, the epithelial to mesenchymal transition, as I think has a primary role to will lead to the TKI resistance. And second question is which of the following TKIs has shown promise in clinical trial for treating TKI-resistant HCC by targeting the fibroblast growth factor receptor pathway? I think this one also has raised an important issue that how we know that lenvatinib is a very good drug compared to sorafenib. However, sometimes it's not easy to manage the patient, especially if we can see here that in the learning point based on the case that this patient, even though it's based on the HCV infection, however, this patient also diagnosed with the metabolic dysfunction associated fatty liver disease. So we know that in this kind of patient it's not easy to control the tumor aggressiveness sometimes in the clinical practice. So I think maybe the answer can be the second one, cabozantinib. It's also one of the options if there's a TKI resistant. And what kind of the immunometabolic changes are frequently observed in MAFLD-associated HCC? So I think looking at this, I think this has raised the important issue regarding the MAFLD-associated HCC. About, I think the number one is also very important, also number two, because there's an inflammatory condition that might be reduce the T regulatory cells in MAFLD-associated HCC. And I think this last slide that what role is the gut microbiome postulated to play in the context of the TKI-resistant HCC with MAFLD. So I think this has been still a new area that we need more data to conclude about this condition, even though we know that gut microbiome is very important in the intestinal permeability. So I think looking back at this case, that in the future we might change the sequential algorithm for the HCC management treatment, as mentioned previously by the two previous speakers, about that how we can change the strategy and then doing the combination and then which one it starts first, when to switch and other things. I think that's to conclude that this is the complex case. Thank you very much.
Thank you, Dr. Cosmas. In the interest of time, we will not have any questions. Thank you, sir. We will now move on to the last topic for the session, which will be carried out by Dr. Udit Chauhan, Associate Professor, Department of Interventional Radiology at AIIMS Rishikesh, for the liver quiz and case summary.
So to begin with, I have this first case. This is a 55-year-old male with chronic liver disease. So for the audience, this is the non-contrast image, the arterial phase image, portovenous, and the delayed image. So can we have the poll? These are the options. So I think okay, so far 42% have voted for cholangiocarcinoma. So if we go back, we can see if we apply lyrides to here, so we have a lesion which is very faintly enhancing here in the arterial phase, but there is a definite washout with a definite capsule over here. So basically this is hepatocellular carcinoma. This is the second case. This is a 14-month-old child who presented with hepatomegaly and nodular liver, and for audience purpose, this is the arterial phase and this is the delayed phase. This image is the maximum intensity projection image of the liver in the arterial phase, and this is the same image in the sagittal plane. So these are the options. So audience say it is HCC. Basically, the history says it is a 14-month-old child, and if you see, the lesions are enhancing in the arterial phase, but these lesions are showing some peripheral nodular enhancement, and there is continuous filling up in the delayed phase. Very importantly, you can see here, this is the dilated hepatic artery, and the infraceliac aorta is very thin. So can we have the answer? Anybody from the audience? It is infantile hemangioendothelioma. This is the third case. So this CT was done for pain abdomen, and this is the triple phase CT, non-contrast, arterial, portovenous, and the delayed phase. Again the same options. Can you have the poll? Okay, so the answer is correct. Most of you got it right. It is NET metastasis. So why we say this is NET metastasis? Because we have following features. So you can see these are, the most important point here is you can see these are blood fluid levels in the lesion. Even in the non-contrast stage, you will see blood fluid levels. Lesions are enhancing and there is no washout. So this is basically metastasis from a hypervascular lesion, which as per the options it will be NET. So take home points is we have seen 3 cases, all of them were showing enhancement in the arterial phase. So that means anything which is enhancing in the arterial phase is not HCC. That is most important thing. Another thing is we should do a triple phase study for any liver lesion. Triple phase study comprises of NCCT, arterial, portovenous and delayed phase. Again, during the time of scanning, we can tailor the study. If the lesion appears to be a cholangiocarcinoma or hemangioma, we can tailor our delayed phase accordingly. We can do MRI. If the CT doesn't give any answer, we can go for MRI also and utilize hepatobiliary agents whenever they are available and possible. While evaluating, we have to be systematic. We cannot jump from one phase to another. Always go from one phase to another phase and follow the lesion till the last phase which is available. Always see for the ancillary findings like fat, calcification, necrosis, capsule retraction, fluid levels, etc. MRI base sequences are very important. We need to see if there is a scar, what kind of a scar it is. It is hyperintense, it is hypointense, any kind of bleed and any other signals. And whenever you find locoregional lymph node, you find metastasis to adrenals, omentum, always do a screening chest CT for staging purposes also. Now this is the algorithm for treatment of HCC with metastasis and preserved liver function. All this we have been discussing in this session so far. So basically, we treat the primary lesion as well as the metastasis. So if there are, the protocol, this is based on the novel concept that came up with this paper in 2021, which is a TATI protocol, and it says we have to apply TACE, ablation, TKIs and immunotherapies. So we have ablation and or TACE. Depending on the lesion in the liver, the variation of TACE can be done, plus TKI with or without immunotherapy. In cases of bony metastasis, we can go for radiotherapy or RFA of the bony lesions and follow up with M-RECIST. Now, just for the audience, this is how the fat looks like: calcification, lesion which is showing central necrosis, capsular retraction. These lesions, most of them show blood fluid levels, and this is portal vein thrombus. So these all ancillary findings we need to see on a CT, so to add our diagnosis. Thank you.
Thank you, Dr. Udit. Conclude the session.
Yeah. Thank you, everyone. Thank you, the chairmen and moderators, for the beautiful session. Now we can move for the session 8, entitled as Biliary Tract Cancer, the Emerging Challenges. I would like to invite the chairpersons, Dr. Randhir Sood, Department of Gastroenterology and Hepatology, Medanta Hospital, Gurugram; Dr. V.M. Dayal, Department of Gastroenterology, IGMS Patna; Dr. G.N. Ramesh, Department of Gastroenterology and Hepatology, Aster Medicity, Kochi, Kerala. I would also like to invite the moderators, Dr. Bhaskar Nandi, Clinical and Transplant Hepatology, Amrita Hospital, New Delhi; Dr. Sridhar Sastrukar, Professor Liver Transplant and HPV Surgery, ILBS, New Delhi; Dr. Arun Valsam, Department of Gastroenterology and Hepatology, Amrita Hospital, Kochi. Sir, please join the stage.
Good evening, ladies and gentlemen. Let's start. We have this session of biliary tract cancers, the emerging challenges. And the first speaker, Dr. Robert Lewis, who is from Mayo Clinic, Division of Gastroenterology and Hepatology, College of Medicine and Science, Rochester, New York, USA. And his topic is intrahepatic cholangiocarcinoma and hepatocholangiocarcinoma diagnosis and management. So, Professor Robert Lewis, is he giving virtual? Yep.
Good afternoon. I would like to thank Professor Sarin and the organizing committee for the opportunity to present to you today. I wish I were with you in person. I'll be talking about intrahepatic cholangiocarcinoma and hepatocholangiocarcinoma diagnosis and management. I have a few disclosures here. So I'll start with the discussion about imaging, which often is the first clue that we are dealing with an intrahepatic cholangiocarcinoma or a mixed tumor. And we typically will do triphasic imaging or multiphasic imaging using cross-sectional CT or MRI. And this image here shows a number of features of intrahepatic cholangiocarcinoma, which can be mimicked by mixed hepatocellular cholangiocarcinoma as well. So we don't see this here. I'll show it on the next slide. We have this typically progressive arterial to delayed phase enhancement. So the enhancement of the tumor progresses through the arterial and the portal to the delayed phase with no washout. There is often a rim of enhancement around the tumor. We don't really see that here. But what we do see here is some capsular retraction, where there's retraction at the edge of the tumor. There's sometimes focal biliary obstruction, as we see here, and there's frequently vascular invasion as well, or there can be vascular invasion as well. This shows the different phases, so we can see through the arterial, a portal, and a delayed phase. And we can see here the peripheral enhancement that I mentioned, the fact that early on there is less enhancement in the substance of the tumor. It increases and becomes most intense late in the later phases of the sequence, and there is no washout. Now, mixed hepatocellular cholangiocarcinoma may actually be more common than we think or expect. This is from the Cancer Genome Atlas Project for Hepatocellular Carcinoma. And one of the things we did in this study is we looked at cholangiocarcinoma-like gene expression. And you can see that up to about 8% of the tumors actually had a cholangiocarcinoma-like gene expression, even though they had all been reviewed by a pathologist and shown to be to have typical histologic features of hepatocellular carcinoma. And so about 8% of histologic HCCs had a cholangiocarcinoma gene expression pattern. As you'll see down here, a proportion of them also had mutations in the IDH1 or 2 genes as well, which is typical of intrahepatic cholangiocarcinoma. The histology of the biphenotypic tumors shows elements of both hepatocellular and cholangiocarcinoma. So here, for example, this is the same tumor, but you can see a portion of the tumor has the cords typical of hepatocellular carcinoma. And you can see canaliculi, typical again of hepatocytes and more hepatocytic differentiation. And then over here, we see a more glandular pattern, and we see a glandular pattern with cytoplasmic staining, more typical of a biliary type of a tumor. So both of them existing within the same tumor. So the mixed HCC cholangiocarcinomas may have different imaging patterns as well. Here is one that has a peripheral hyperenhancement in both the early and late phases, with no really significant progression of the hyperenhancement in the central part of the tumor. And here's another one where we have a focal late arterial hyperenhancement in a portion of the tumor, in a separate area of delayed enhancement in a different portion of the tumor. These mixed HCC cholangiocarcinomas may be FDG avid on PET-CT, and you can see here both the main lesion in the liver, very avid, but also quite helpful, this little lymph node shows evidence of FDG avidity, and PET-CT can be helpful in identifying positive metastatic lymph nodes from the primary tumor. So from an imaging study perspective, the majority of cases will image like either intrahepatic cholangiocarcinoma or metastasis. Occasionally, the enhancement pattern or associated imaging features can suggest a biphenotypic tumor. Having AFP, CA19-9, or CEA values that are discordant with the most likely imaging diagnosis should prompt a biopsy looking for a mixed tumor. And often, in a proportion of cases, we'll have elevation of both the AFP and CA19-9. But if a lesion looks like an HCC but has elevated CA19-9, or it looks like an intrahepatic cholangiocarcinoma but has elevated AFP, then you want to biopsy it. The PET-CT is markedly FDG avid in the majority of these lesions, and that may also prompt a biopsy. And it's important for treatment purposes to think of and suggest a diagnosis other than HCC, because as we will discuss, typically we treat these mixed HCC cholangiocarcinomas as a cholangiocarcinoma, not as an HCC. So we think about the pathology of the HCC. This is an example of intrahepatic cholangiocarcinoma. This is an example of a small intrahepatic cholangiocarcinoma. And you can see here again, it has, this one has glandular elements that's typical of cholangiocarcinoma, and it has the increased stroma as well. So next, I'd like to discuss a new clinical staging system that we developed that has just been recently accepted for publication in the American Journal of Gastroenterology. We call it CSICA. It's a new clinically based staging system for intrahepatic cholangiocarcinoma. And I'll report here the establishment and external validation. So in terms of the derivation cohort, these were patients that were seen at Mayo Clinic in Rochester. We started out doing a search of a computerized database, found 771 patients, excluded about 335 of them for a variety of reasons, ended up with a derivation cohort of 436. And then as we did our analysis and came up with a proposed staging system, due to missing data, we were unable to subclassify 11 of these because they were missing CA19-9. So we ended up with 425 patients staged using this proposed system. And in stage 1, we had 31, stage 2, 94, stage 3, 158, and stage 4, 142. And we built a 4-stage staging system that I will describe briefly here. So after a diagnosis of intrahepatic cholangiocarcinoma, if a patient had ECOG performance status of 2 to 4, they were rated as stage 4. If they had an albumin of less than 3.5 grams per deciliter, they were rated at stage 4. If they did not meet these criteria but had peritoneal endodistant metastasis, then they were stage 3. If they had multiple tumors or satellites to a primary tumor, they were stage 3. If they had a single tumor but a CA19-9 greater than or equal to 1,000, they were stage 3 as well. Their CA19-9 was 100 to 999. Their largest tumor diameter was 5 centimeters or greater, and there was evidence of direct regional metastasis. They were staged as stage 2. And those individuals who had then CA19-9s less than 100, largest tumor diameter less than 5 centimeters, no evidence of direct regional metastases, and they would of course have had to meet these criteria, a performance status of 0 or 1, and an albumin greater than 3.5. They were individuals with stage 1. So looking at the derivation cohort, you can see here that we had a very nice distinction in outcomes between the patients in the different stages, stage 1, 2, 3, and 4. And this was fairly similar in the validation cohort as well, where we had a good distinction between individuals in the different stages. If we compare the derivation with the validation cohorts, you can see we had fairly similar outcomes in the different stages, in the different cohorts. The validation cohort was assembled from Mayo Clinic, Arizona, Mayo Clinic, Florida, and the University of Calgary in Canada. And then if we build the outcomes for all the 4 cohorts, all the 2 cohorts, the derivation plus validation cohorts combined, you can see the result here as well. Now, when we compare this staging system, the clinical staging system, with this, what we call clinical TNM. TNM, often you need to have done surgery in order to get an accurate, conclusive TNM. But of course, most of the patients with intrahepatic cholangiocarcinoma are not candidates for surgery. And so we built what we call the clinical TNM based on radiology when the patient had not had surgery. And what we see here is that the TNM does not discriminate as well between particularly the later or more advanced stages of cholangiocarcinoma, of intrahepatic cholangiocarcinoma. So we did the concordance indices, and you can see here this proposed C-sicker staging system had a concordance index for all patients of 0.693, almost 0.7, whereas for the TNM it was 0.643. And we broke it down also by the type of treatment the patients had, and you can see that the concordance index was highest for those who received local regional therapy or chemotherapy with radiation therapy. And again, and several types of treatment. Here we had significant differences between the performance of the C-sicker staging system and the TNM staging system. So I hope you will try to use this and we'll get some validation from India as well. Now, what we learned from this also is that early detection improves patient outcomes. You can see that those with early stage disease had actually 5-year survival of about 50%, quite remarkable for patients with intrahepatic cholangiocarcinoma. And so I will just briefly mention that it's really important that we develop markers for early detection of cholangiocarcinoma, and particularly for those individuals that we can determine as being at high risk for cholangiocarcinoma, but also perhaps as part of multi-cancer early detection panels that we can use for the population broadly as we are screening them for other more common cancers as well. In terms of treatment of intrahepatic cholangiocarcinoma and mixed HCC cholangiocarcinoma, as I mentioned, surgical resection is recommended for technically resectable disease in patients with acceptable liver function. Please consider liver transplant now for patients with limited disease up to 3 centimeters in the context of cirrhosis. There are a number of active research protocols underway examining this for patients with intrahepatic cholangiocarcinoma. Consider stereotactic body radiation therapy, proton beam therapy, or transarterial radioembolization for patients with locally progressive disease that is liver limited. It's important for intrahepatic cholangiocarcinoma that we sequence all these patients looking for FGF receptor 2 fusions, IDH1 mutations, BRAF mutations, ARB2 amplifications, or mismatch repair deficiency, because each of these is amenable to specific targeted therapies. I'm sure Dr. Abu Alfa will go into more detail here. And in the absence of specific mutations, current first-line steroid therapy is a combination of cisplatin, gemcitabine, and durvalumab. And in the second line, FOLFOX, or the combination of 5-FU plus nanoliposomal irinotecan has been shown in a Korean study to be positive. Now, just in closing, I would like to bring to your attention some studies we are doing, try to understand the genetic risk factors for cholangiocarcinoma, and I'd really like to encourage anyone who is attending this meeting who is interested to contact me about this. We formed a global study of inherited genetics of bile duct cancer. I'm going to skip just briefly, just make the point that host genetics plays a role in the development of these cancers in addition to the other things that we know of as risk factors for cholangiocarcinoma. We are looking for single nucleotide polymorphisms that are associated with increased risk of cholangiocarcinoma, and doing exome sequencing as well, so that we're looking for common risk variants as well as rare risk variants. And we do sort of standard genome-wide association studies to identify the SNPs. And just to say that in early discovery phase results from patients of European descent, we have already identified a number of significant loci, both for overall as well as for extrahepatic cholangiocarcinoma. For intrahepatic, there are some areas that are suggestive but do not reach statistical significance. And we were recently awarded a grant by the National Institutes of Health, and our goal is to sequence 7,000 cases and 7,000 controls over the next 5 years. We currently have 82 sites and collaborators from 31 different countries. Our emphasis is on global genetic diversity and increasing representation from populations throughout the world. And we hope you will consider participating and joining us in this endeavor. These are the sites where we currently have sites throughout the globe. I'd like to acknowledge participants thus far. And to collaborate, please contact me at roberts.lewis@mayo.edu. And thanks again for the opportunity to present at this meeting.
Thank you, Professor Lewis. That was a wonderful talk. Any comments from the brief comments from the panel, please?
Thank you for the wonderful talk. Just one question. So the most important prognostic factor happens to be lymph nodal metastasis. But in the study, in the algorithm that you showed, lymph node, does it come to the distant mets and it comes to stage 2? So is it because that lymph node mets was not coded in the study, or did you consider lymph node as less of a prognostic marker than ECOG and performance status?
This was a recorded lecture, so we can keep looking up, but he's not there. So we can start. I think we didn't know it. Sorry. So we'll start with the next.
Okay, moving on to the next stop, which is on biliary tract cancers, unfolding the pathways, targets, and evolution of immunotherapy. Our speaker is Dr. Ghassan Abu Alfa from Memorial Sloan Kettering Cancer Center, Vail Medical College, Cornell University, New York, USA.
Thank you very much, everybody, and congratulations for Professor Sarin, Professor Sharma, and of course the whole organizing committee for a great meeting. A lot of learning opportunities here. Again, I second what my colleagues have said. Would love to have been in person, but thanks to the technology, we'll be able to connect, and I'll share my screen now. And if anything, I was entrusted on, bear with me 1 second, just to make sure that I got the screen right. Okay, 1 second here. And just confirming that you are seeing my screen at the moment.
Yeah, we can see.
Very good, thank you. So I was entrusted on talk about the unfolding the pathways, targets, and evolution of immunotherapy. And I have to say, I love very much the title. Very thoughtful, very strategic, and visionary, because really what we're going through. These are my disclosures, and these are my contacts. Please feel free to copy whatever you would like from the screen, or take a picture of the QR code, and I'm more than happy to connect at any time, as many of you know, for any academic, any clinical, any research questions at any time. And of course, the organizers have my contacts if you miss or are not ready to take them right now, but happy to connect at any time. So with this said, I'm going to start the story with, of course, the clues that we have. We'll look at the data we have. We'll see what the issue is based on the question that was brought up in the title. What is the model that we can really work into to see the disruption? In regard to the clues, I understand biliary cancers have been looked at into 3 diseases based on anatomy. This is simplistically what we thought about 20 years ago. But if anything, we know very well that this is really not anymore necessarily the only way we can look at the disease, being intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, or gallbladder cancer. If anything, we know that even at the minutiae of a pathology, nowadays we can even be able to clue about what are the genetic alterations that can be there. If anything, over here, this is great work by one of my colleagues, happy to be my brother, Dr. Abu Alfa at University of Vermont, looking into, interestingly, the peripheral tumors. It appears to be when they are really in the periphery, maybe IDH1 mutation will be probably the more apparent alteration that can occur. And our colleague also, Dr. Larry Schwartz, the chairman of radiology at Memorial Sloan Kettering, where we are, brought up another perspective, which again is beautiful, that radiology, after all, is not anymore looking at a imaging or at a sequence of images, but really looking about many components, among which the burden of the tumor, they change the tumor burden, consumption of sugar, skeletal muscle index, the bone marrow metabolism, heterogeneity and shape. And of course, you can see that we are not anymore into the science of simply descriptives, but rather looking at very many details and many clues all coming at the same time. And of course, this is a good example about where we're going with this. This is a superb study that was done by our colleagues in Japan, looking into the occupational cholangiocarcinoma after exposure to certain chemicals. And you can see that we're not anymore only delineating that said the pathology is cholangiocarcinoma or not, but rather we're able to even see what are the genetic alterations specifically happen at different sites of the tumor. So this was really meant to really set up the stage for what really going to be talking about next, which is, of course, the genetic modulation that can occur in those diseases. This is nice work that our colleagues have brought in from China, looking into the East and the West perspective in regard to cholangiocarcinoma. And we can see, yes, there could be differences. I really just would call descriptive at this point in time. We're not yet to decide really what is the detailed alterations and how to target them specifically for different ethnicity, but at least we know, yes, there could be different parts, as you can see to the extreme right of the screen. Add to this, we ourselves at Sloan Kettering, we published that already. It was beautifully done in the clinical cancer research with Dr. Lowry, who was with us at that time. And you can see that there is a certain mutual exclusivity for genetic alterations. In other words, if there is, for example, an IDH1 mutation, there will be no FGFR2 alterations, and vice versa. This is not necessarily perfectly all the time the correct thing, but definitely it gives us some clues about that, yes, alterations can be sometimes mutually exclusive. So as you can see, it's not anymore about looking at the pathology, it's not anymore looking at anatomy, but looking at really minutiae of details coming from the genetic alterations, coming from the radiologic variations that can tell us how best we can describe these tumors and go along the right pathway for treating it. So, what's the data? The data, to be fair, started, of course, mostly with chemotherapy. This is ABC02 study, well-known study, and we all practice it, being in India or anywhere else. Combination of gemcitabine plus cisplatin compared to gemcitabine, improvement in survival, and this became a standard of care that stayed with us for a long while. We no doubt, and give credit, all our colleagues have tried very different ways to add on alter in regard to the chemotherapy. And for example, here we have the SWOG 1815 looking into gemcitabine, cisplatin, nab-paclitaxel. As we know, the study ended up being negative. It did not really go any further that we can pursue with this. Number two is we have the ABC06 of FOLFOX. Again, positive study as a second line, even though there's debate about what could be second line after platinum followed by platinum. And of course, we have the NIFTY study looking into liposomal irinotecan plus 5-fluorouracil with an improvement in survival. I'm not necessarily showing here the details of them because you definitely know them all and you can see them all in the publications that really manifested them all details. But I would say there's all variation on the same subject. We have to think out of the box. We have to think a little bit in a different way. So, of course, what else to do but to bring the genetic alterations? And to be fair, we were proudly leading a lot of those efforts here from Sloan Kettering. This is clearly a study that looked into ivosidenib for mutated IDH1, and we showed over here that there was no difference in regard to survival when you look into the mutated IDH1 treated with ivosidenib versus placebo, but when we pretended that there's no crossover that could have occurred, we see a major difference where there's double of survival, 5 up to 10 months with the use of ivosidenib. Interestingly, one of the important clues that we brought in, what happened, and I'll give you this as a good example before we come to the FGFR2, what happened for a patient if they progress on the therapy? Of course, they can change the mutation because those tumors are very smart. They can be stressed out enough that they will change the mutation. And this is, for example, another one. Now with the FGFR2, we have the great response that we had with BGJ398, excellent response, and we can see here Dr. Javli, who led on the effort, and we were with him, did that. We have also the pemigatinib that I led globally that shows great responses, and we showed improvement in survival. We have also the alterations that can really show that when the fusion happens, you can really benefit more from therapy. And over that, we have more studies. And on purpose, I'm showing all of that because trying to illustrate the point. We have the tirazapatinib, we have the futibatinib, which is a little bit later on, just brought up by Dr. Goyal, superb work that she published in New England. And we have now, even for the HER2, the Horizon study with zanidatamab by Dr. Harding, also from Sloan Kettering. So what do we do with all of this? I mean, how even this is just was published yesterday that probably they're going to be stopping all their effort, but nonetheless, at least we acknowledge that the related drug. And also we have the tukibatinib drug from Japan, but there's too many drugs. How do they occur? How do they work? That's really what I'm coming down to the point of, which is what the issue. Interestingly, the issue is that, as I just already alluded to when I spoke about the ADH1, when you have genetic alteration and you have a certain mutation, you clearly can actually cause, as progression occurs, the mutation to really change to another mutation. And the question is, how does this occur? There's a beautiful work that Dr. Goyal described beforehand that, look, when you stress out the tumor, you can come to another specific alteration that can really be the gatekeeper that preventing the tumor from responding to the therapy. So here in the IDH1, we see this nice work from Dr. Harding here at Sloan Kettering, where in IDH1 changed to IDH2. And we can see the same thing happen in everything else. So is this really by random? That's really the question. And interestingly, probably not, because this is nothing to do at all with what we're talking about, but to illustrate the point, anti-FGFR will actually, angiogenesis, evolve in a very random way because we don't know better. But interestingly, we know very well that those blood vessels that really are growing very fast to try to surpass the challenges of the tumor actually will be blocked at some point in time here and there based on the resistance pathogens. And that's why they grow not by what we call random, they call by deterministic perspective. To give you the illustrated point, here's like a picture of a beach. You know, if you tell me, if we ask ourselves, where are people sitting? You can say, oh, they're sitting by random. Not really. Because if you go and ask each one of them, why are you on the beach? You might probably hear from the people who are sitting in the front, you know, we like the water, we like to swim, that's why we're sitting in the front. The people who are in the back, who are families, you see more umbrellas because we want to be closer to the facilities, closer to the food, we have kids with us. And those people are like couples, maybe say, you know what, why not just be together? We don't care where we are. And out of nowhere, you saw that we were able to change a random picture to a deterministic picture for the beach. And same thing happened in regard to the genetic alteration. This is like really a chaotic event that really has its own built-in, same like as we see in the sickle cell crisis. We think it's really random, it's not, it's chaotic. Chaotic means that there is a certain prediction to it per se. And that's why this is what we're working to, is to look at the baseline genetic alteration got to, for example, FGFR2, look when we give a certain therapy, and look at the post-anti-FGFR2 genetic alteration. And don't be surprised, there will be ultimately a clear, deterministic alterations that will not be out of nowhere a certain random. Why this is important? Because what if somebody got treated with pemigatinib as first line, get a certain resistance? Could they get pemigatinib again at some point in time? They might. And that's really what we're working on. Because as Einstein has said, God does not play dice with nature. This is all determined beforehand. However, there's a certain disruption that we all came into hear about, which is the genetic alterations. Now, not anymore the priority because we have the immunotherapy. There's a beautiful work of Topaz 1 study showing adding on durvalumab to gemcitabine cisplatin will improve on outcome. And now we even have the combination of the Keynote 966 by Dr. Kelly, who really now brought in the gemcitabine cisplatin plus pembrolizumab, again showing improvement in outcome. So we have a lot of things going on at the same time, but if anything, the effort that really we're very keen on is to try to even dissect further, take out the randomness away, and build in more of the genetic alterations and see what it means to make sure we treat people correctly in sequence. If anything, I summarize that genetic alterations based therapies are definitely there to stay. Resistance-based alteration and applicable therapies are to be studied further. And no question, the checkpoint inhibitors disruptive model is really took us from the left field. Good news for the patients, but definitely we have to put in perspective. I thank you very much for listening. I tried to really catch up because of the delay that the session had, because I was live, and I hope I helped the moderator in regard to put it back on speed, on time. Thank you very much for listening.
Thank you, Professor Abu Alfa, for a very excellent talk about the current state of treatment of biliary tract tumors with immunotherapy. I just have a couple of questions. You now that with the Topaz 1 and Keynote 966, the chemoimmunotherapy model is kind of the first line for the treatment of these tumors, advanced tumors. So, but there will be some resistance to these drugs. What do you think is in the pipeline for second line if the first line stops working?
Excellent question. So there are two pathways that you can think of for that purpose. One of them is to simply look what genetic alterations there are there, and we think probably about 30 to 50% will have genetic alteration and give that therapy per se. But on the other hand, you can go to one of those second-line therapies that I brought in, like, for example, FOLFOX or liposomal FU, etc. But the novel question is the following. If we change to chemotherapy in second line, like FOLFOX or what have we, do we keep the immunotherapy? We don't have the answer to that yet, but that's something that we're looking into at this point in time, because we think that the stuff like, the structure of the building is really based on the checkpoint inhibitor, and we think that probably ultimately they might have a role to continue, but this is yet to be proven.
And any thoughts about the combination of molecular therapies with the immunotherapies?
Superb question too. You are thinking ahead of the things going on, but yes, by all means, we are doing that as we speak, looking into combination of chemotherapy / immunotherapy / biologic therapy. The question is, do we really want to do strategically everything together, or should we really sequence things? Not sure yet, but definitely this is in the work as well. The arguments biologically or scientifically for them is valid, but we just have to confirm it.
Thank you. Moderators, any questions?
Thank you for a very interesting talk. I have got a somewhat basic question. How do you select your patients whom you would like to subject to molecular or immune check therapy? And which all patients will you apply for genetic alterations? Do you have any selection criteria or any inclusion criteria for these?
Thank you so much. That's a great point as well. To be fair, all patients who come across, we will check all of them for genetic alterations. We don't really select or pre-select who might get genetic alteration screening. If we have the genetic alteration, we don't get excited about saying, okay, great, we have it, that's it, we have to change therapy. Absolutely not. We just keep it on the shelf. When we need it, we will use it. On the other hand, in regard to the second-line therapy, I personally, if the insurance will cover the keeping of the checkpoint inhibitors, I might keep on chemotherapy second line and keep the immunotherapy on board. If I have an alteration, however, of course, I will apply the alteration therapy, like, for example, pemigatinib for FGFR2 or ivosidenib for DH1.
Thank you.
Sure.
Thank you very much. I think we'll close this part of the session and move on to something interesting. It's a debate. I think the first debate for the day. The debate is the topic for the debate is liver transplantation in hepatocholangiocarcinoma. And we have two speakers, one of course for transplant, the other for the non-transplant management options. My privilege to invite online Dr. Abhinav Kumar. Dr. Abhinav Kumar is in the Division of Abdominal Transplantation Surgery, Thomas Starzl Transplantation Institute, Pennsylvania, USA. And he's going to be giving his side of the topic or the coin, transplant, the strategies and outcomes. Over to you, Abhinav.
Hello, everyone, and
very good. Thank you very much.
Welcome to all from Pittsburgh. I'm sorry I'm not able to be there in person, but I thank the organizers for the kind invitation to present. My topic today is liver transplant for intrahepatic cholangiocarcinoma. Should it be done? And my stance is yes. Just a reminder, intrahepatic cholangiocarcinoma represents part of the spectrum of cholangiocarcinomas, which includes hilar as well as distal cholangiocarcinomas. All have poor prognosis, as shown by this series from Johns Hopkins of cholangiocarcinomas intrahepatic, which demonstrates that Without surgical treatment on chemotherapy, 5-year survival is 2%. With resected with a positive margin, 5-year survival is still poor at only about 10%. But those patients who can be resected with a negative margin do have the possibility of long-term cure with 5-year survival of 30% in this group demonstrated. And so as a result of this, liver resection remains the gold standard for the treatment of intrahepatic cholangiocarcinoma. The problem, however, is that the majority of patients are unresectable at the time of presentation. Probably only 20 to 30% are going to be resectable at most. And there are many reasons for this. Resection can't be done if there's obviously distant metastases or peritoneal disease or poor patient status. But also if they have diffuse bilobar involvement or underlying liver disease with portal hypertension or inadequate future liver remnant. Now those three, as shown in the green, do not necessarily represent contraindications for transplant, though they are contraindications for a resection. And certainly transplant is an option in these patients, as shown by this study that looked at the National Cancer Database and demonstrated that in patients who had a transplant compared to matched controls that underwent a surgical resection, that outcomes were virtually identical. So transplant could achieve equivalent results as compared to someone who had a successful resection, and certainly much better than the patient who was undergoing systemic chemotherapy. And there have been a number of series that have reported on patients with intrahepatic cholangiocarcinomas and outcomes. While the early series were quite dismal in terms of outcomes, more recent series have demonstrated that with careful selection, you could achieve good results, as shown in this 2016 series by Sepp Soshin, that in patients who had very small tumors, less than 2 centimeters in size, you could get a 5-year survival of 65%, roughly about what you'd see equivalent to many HCC patients that receive a liver transplant. So I think liver transplant and resection are not necessarily competing with each other, but represent complementary modalities of treatment for patients, with some patients ideal for a transplant, i.e. patients with underlying liver disease or those with very small tumors. But regardless, a 5-year survival of 30 to 40% is probably not adequate for most people when we talk about liver transplant. So can we do better than that? And yes, I think we can, especially with modern transplant oncology. What exactly is transplant oncology? It's essentially encompassing multiple disciplines of transplant medicine oncology to push the envelope of treatment of tough hepatobiliary cancers. And this has enjoyed some success in treatment of metastatic colorectal cancers or peripheral or hilar cholangiocarcinomas. And so perhaps similar can be said for intrahepatic cholangiocarcinomas. And that was certainly the thinking behind this series from the group in Dallas that looked at this regimen to select patients for treatment with a transplant. And essentially it looked at a stringent selection criteria of who would qualify, followed subsequently by neoadjuvant chemotherapy, and then demonstration of disease stability over a period of 6 months as a way to prove favorable tumor biology, followed subsequently by a transplant and then adjuvant therapy. And using that regimen, they demonstrated a 5-year survival of 80%, albeit in a very small number of patients, only 6 patients in this series, but followed up subsequently with a larger series of 18 patients demonstrating about 57% 5-year survival, certainly much better than those patients that were listed for a transplant but actually didn't receive a transplant. So based on this, we devised our own protocol for transplant of these patients, which essentially uses strict inclusion criteria, excluding anyone with any evidence of extrahepatic disease, including any nodal disease, and relying on a living donor liver transplant for these patients. And there's several advantages to a living donor transplant over deceased donor transplant for these type of cases. Specifically, you can decrease the waiting time and hence minimize the risk of progression. It allows you to optimally time the transplant, especially with neoadjuvant and then subsequent adjuvant therapies. There's immunologic advantage, and therefore you can minimize immunosuppression in these patients. And you're not utilizing the very valuable deceased donor organ. Now, obviously, this has to be balanced by the disadvantage of the risks to the donor, but the majority of donors are actually quite well accepting of this. And in fact, a living donor transplant program forms the cornerstone of our own transplant oncology program, and we've utilized this almost exclusively for these complex hepatobiliary cancers that we've treated. So this is our protocol. It starts first with the diagnosis of intrahepatic cholangiocarcinoma, followed subsequently by evaluation to exclude very carefully any evidence of extrahepatic disease. And if the patients then subsequently qualify, the evaluation of a potential living donor and approval. And if a suitable living donor is found, the patient then subsequently undergoes neoadjuvant chemotherapy with gemcitabine and cisplatin, which are given over a period of 6 months. And during that period of time, the patient has regular and repeat imaging, as well as perhaps local regional therapy. And the repeat imaging is done with advanced imaging techniques, including PET scanning, to ensure that there's no evidence of extrahepatic disease. And if after 6 months there's continued evidence of stability and no extrahepatic disease, then we subsequently schedule the patient for a living donor transplant. The recipient is first brought into the OR and undergoes an exploratory laparotomy. At the time of that, we biopsy any suspicious lesions and biopsy hilar nodes as well as nodes around the hilum to rule out any nodal metastases. If there are, then we abort the procedure. But if they're not and no evidence of other extrahepatic disease, then at that point we would bring the donor into the operating room and proceed with the living donor transplant. After the transplant, once the recipient has recovered, usually by about 1 month post-transplant, we start them on adjuvant chemotherapy using capecitabine, and we also switch to an mTOR-based immunosuppression regimen by 6 weeks. The patients then have subsequent regular imaging for 5 years post-transplant. Using this protocol, we've now transplanted 7 patients to date over the period of the last 4 years, and this is what our results have been like. On the left, these are the patient characteristics. You can see that they're low MELDs. In terms of the explant pathology, you can see that all of them except one had viable tumor on the explanted liver. 4 had single large lesions, 3 had multiple nodules throughout the liver. These were large tumors. You can see that the median size was 7 centimeters, and the majority of these, 6 out of the 7, were pure intrahepatic cholangiocarcinomas. Now, with median follow-up of 2.5 years, ranging from 0.5 to 4 years, you can see that we have 100% patient as well as graft survival in this group. We've only seen one patient recurrence to date. That was in the lung, and that patient recurred at about 10 months post-transplant and was treated with a resection and continues to do well now, 2.5 years post-transplant, with no evidence of recurrence of tumor. So in conclusion, I think liver transplant is a possible option for select patients with intrahepatic cholangiocarcinoma. Careful selection and multimodality therapy can help to identify patients with acceptable biology that are going to do well with the transplant. And finally, a living donor liver transplant provides the ability to reliably offer this as an option for these patients. So I'll stop there and we can take questions at the end.
Thank you very much, Dr. Abhinav. Please stay on because we're going to have one more, the other side of the coin, and then we can have a discussion on that.
So the other side of the debate, non-transplant management options in hepatocellular cholangiocarcinoma. The speaker is Dr. Prasoon Jalal from the Margaret M. and Albert B. Alkek Department of Medicine, Baylor College of Medicine, Houston, USA.
Hi, can you hear me? Let me put the video on. Sorry. Excuse me. Can you see my slides? Can you see my slides? Good evening. Thank you for inviting me for this talk. Thanks to Dr. Sareen and Dr. Chaudhary and respected chairpersons. I'm going to talk about, excuse me, there are really challenges in the management. Excuse me. Sorry, can you hear me?
I can hear you very clearly.
Okay. No, I don't want to give my recorded talk. I need to change it. That's why I'm saying. All right. You see my slides, right? Sorry. Okay. I apologize because there's supposed to be debate, but looks like there'll be no debate because, firstly, no one wins the debate. No one loses the debate. Everyone wins. Number two, I think I misunderstood, or Dr. Kumar misunderstood the topic, because the topic was supposed to be on hepaticocholangular cancer, not just intrahepatic cholangio. Am I correct? Hello? Can you hear me?
Yes, we can hear you. It was, you know, in hepatocholangiocarcinomas.
I see.
The
all right, so
non-transplant treatment strategies.
Right. So although he is correct, it's more close to aligned to intrahepatic cholangio, but hepaticocholangia is a totally different entity. As you all know, it's a mixed tumor, so it has so many different names, and that's a conundrum. And it's not exactly behaving like intrahepatic cholangio, so we definitely need to revise our protocol a little bit more. And there is no easy way to make the diagnosis for overlapping cholangio and hepaticocholangia without doing a biopsy. The scans, the elegant lecture from Robert Lewis gave, as you know, that you may or may not get washout. There will be peripheral enhancement and then going slowly to centrally, but it may not exactly look like either HCC or cholangio. There is no definite pattern. The same way, for the cells, you may get differentiated hepatocytes as well as cholangiocytes. It's always a conundrum because the classification, WHO really struggled for too long and eventually came up with this kind of classification. But as you see on the right side, it's between intrahepatic cholangio and hepatocellular cholangio. So we are in the middle. And if you look at the CR database, this particular entity is a very narrow entity. When I was talking to my MD Anderson colleague, they said, are you sure you're giving a talk on hepaticocholangia, not just intrahepatic cholangio? And that's what it was. So if you see here, slowly it's going up. You will see in male, middle age in 50s, and women in 60s. And it's a diagnostic challenge. That's why my problem is. How do you know this is a mixed or overlap cholangio unless you do a biopsy? Radiology doesn't help very much. If you see the sensitivity and specificity is low. So ideally you should do both. And that causes another conundrum. Then the outcome. Typically, what has been discussed is correct. It is more aligned with intrahepatic cholangio rather than HCC. However, the overall survival, it could be aligned, but still, prognostically, it could be worse than intrahepatic cholangio. So there are several challenges here. How do you make the diagnosis without biopsy? And typically, poor prognostic markers in this situation is up to 5 centimeter. If there is satellite nodule, if there is lymph nodes, often. This is the big difference between intrahepatic cholangio and overlap. This group has more vascular invasion and lymph node, hilar lymph node than intrahepatic cholangio. It could be multicentric and vascular invasion, as I mentioned, high tumor stage, and high level of CA99, and decreased capsule. So typically, again, they don't pick up contrast very well. So if it is hypovascular, treatment is always difficult. And if you were having a surgery and not having enough margin, it's another problem. So here, if you see, most of the patients we diagnose, they are at advanced stage. They're really, when you diagnose them, they're not in a stage where you can do transplant. And if you see in the right side, a small percentage literally came early stage. So how do you make a case of transplanting this particular group? And if you see on this side, most of the hepaticocolangio patients have very poor outcome. This is the post resection, and most of the patients go for resection for hepaticocolangio because it is not advisable to do transplant to start. And if you see the 5-year survival rate is very low, almost 30% because of high recurrence. And when you look even post-transplant, how we look at it, compare with HCC, HCC resection or transplant versus the mixed, the prognosis is always worse. Now, this particular case, this study, they did match in such a way to look for these patients whether go for transplant. But remember, this is also a retrospective study. These cases who were transplanted, they're all handpicked. And then they found that still HCC post-transplant is much better than mixed hepaticocolangio. So the prognosis-wise, it doesn't really work out. And when you compare between resection and the transplant, their outcome is almost the same. So is it worth going for transplant with, you have this donor or cadaver wasting an organ with all the immunosuppression and the cost involved, as long as the outcome is not any better? So I don't feel that transplant is the right thing to do at the moment. We are not there yet. However, a subset of patients definitely can go for transplant. Small tumor, which well differentiated, but you have to biopsy them and you have to diagnose them as overlap cholangio or intrahepatic cholangio beforehand. So how do you improve the outcome post-resection? Always look for the risk factors. Is there any vascular invasion? What's the differentiation? Is it well differentiated or poorly differentiated? What's the tumor markers like? If there is a chance of recurrence post-resection is high, you have to give adjuvant chemo, systemic therapy, or even the Y90 or TACE. This is another study where they compared between surgery, intrahepatic therapy, as well as systemic therapy. And what they found that surgery is always better. The worst is intrahepatic therapy, systemic therapy. So after surgery, then intrahepatic, then systemic therapy. However, this might be changing for future, as people have outstandingly explained in previous couple of speakers. So again, you can use TARE, you can use TACE, you can use systemic therapy, but ultimately, first go for surgery resection. So the problem is there is no standard guideline. Everyone is doing their own way, and we need to do the proper staging and the guidance. Otherwise, there'll be no way to know which way we're treating these people. This is another study where in a post-resection, you can, depending on the liver, how the liver is functioning, child A, B, or C, or post-recurrence or not, you can go for local regional treatment or systemic therapy. And again, it showed the surgical therapy is better. TACE really doesn't work unless it lights up, because remember, these tumors may not be vascular. So what else do we have in our armamentarium? And I think these are the multiple drugs. Dr. Abu Alpha mentioned quite a few of them, and they are all for cholangio, not necessarily has been used for mixed hepatico-cholangio. What do you know that they have used Nexavar, which didn't work compared to gemcitabine and the other combination. So at the moment, we are really not in a position to say we are prime time for transplant. We still have to go for traditional resection and then local regional treatment or systemic chemotherapy. However, in selected cases, you can go for transplant. The data is very limited, particularly this mixed cholangio group. Intrahepatic, of course, there are some good studies come up. Now, this is the data from MD Anderson. If you see here on this side, the immunotherapy is coming and having a wonderful result. And with combination, definitely achieving much more robust outcome. But still, resection comes as a first choice. There is a study recently got published in JHEP reports where they did a survey to see what's going on in the real world for this small, narrow entity, hepatico-cholangio. And what they found, majority of the people still favoring resection. Some small tumors, if they're diagnosed early, then go for transplant. But what is important thing is that is very tiny, 11% have any obvious protocol to manage these kind of patients. With that, I think debate will go on and we'll take more questions. Thank you.
Thank you, Professor Prasun Jalal, for your contribution. Now the debate is open to questions from the House and moderators. Any questions?
A question to Dr. Humar. First question, it was a LDLT performed in intrahepatic cholangiocarcinoma. I want to know how many patients were enrolled to start with or screened, and then they completed the protocol and had a successful LDLT.
Okay, so yes, that I think alludes to an important point, which is this is a highly select population. And screening and appropriate selection is important. The patients can fall off at a number of places. One being that they progress on initial chemotherapy. So, one of the mandates is that they have to maintain 6 months of stability of disease on existing chemotherapy. So if they progress on that, i.e. develop metastatic disease or even actually have hepatic progression of disease, then that excludes them from the protocol. So we did have a few, but it's actually the minority that were excluded once they were there. The additional place where they can be excluded is at the time of exploration if they have any evidence of extrahepatic disease, including nodal disease, when we explore them before we bring in the living donor, then that would also exclude them. So of the 7 that we transplanted, we actually took 8 to the operating room, and 1 was excluded in the OR because of positive lymph node disease. So yes, there's probably at least I would say, at least a 30% attrition rate for patients once they enter into the protocol. It's not everyone that will go on to completion. Probably at least about 30% will fall off at one of those 2 places.
Thank you. One more question. So if it is a mixed etiology, as the topic is, if it is a mixed hepatocellular cholangiocarcinoma, will you put the same protocol or you have excluded them?
Yeah, so in our experience, and we've looked at this a number of times at ours, our mixed tumors behave actually almost exactly as our intrahepatic cholangiocarcinomas do. And I think if you look at some of the slides that person had shown, comparing HCC versus intrahepatic versus the mixed do very similar in terms of outcomes, prognosis, and certainly with transplant, their outcomes is very similar to those who have intrahepatic cholangiocarcinoma. So we treat our mixed patients pretty much the same way that we would treat pure intrahepatic cholangiocarcinoma patients. They behave very differently from your HCC patients, and so we certainly do not treat them as an HCC patient. We would treat them like as a cholangiocarcinoma patient.
Thank you.
Dr. Charles.
Yeah. Thank you, Dr. Abhinav, for that excellent talk. And when you said you switch to everolimus-based immunosuppression post-transplant 6 weeks, do you completely stop TAC, and what would be the level of everolimus that you look at?
Yes, so yes, you're right. We completely stopped the TAC at 6 weeks and switched them over to everolimus, and we're usually targeting an everolimus level somewhere around 6 at that period of time.
Thank you. And
we maintain them on just dual therapy with everolimus and Cellcept, mycophenolate mofetil, no long-term steroids. Usually a low dose of mycophenolate mofetil, either 250 twice a day or 500 twice a day, and everolimus to maintain a level somewhere between 4 to 6.
Yeah. And one more question. When we transplant patients for hepatocellular carcinoma, at times the explant comes as a combined hepatocholangio. And in such patients, do you recommend giving adjuvant capecitabine in such patients?
So I'm not sure that the adjuvant at that point will be a benefit. We haven't done that because I think it's the neoadjuvant part that probably has more of a beneficial effect. And these patients have not received the neoadjuvant therapy anyways. So to date, no, we have not done adjuvant therapy, though that may be an indication because when they do have on the final explant a mixed pathology, at least in our experience, their outcome is significantly worse than those that have a pure HCC. So I think that may be a strategy that may be worthwhile adopting because we've had good luck with the adjuvant regimen in those 7 patients. As I said, we've had 100% patient survival. So I think that might be a good strategy that those patients should get additional adjuvant therapy.
Yeah. Thank you, sir.
We have the last question from here.
My question to Prasanth, sir. Sir, the patient of hepatitis B with child age cirrhosis with a small HCC fit for liver transplant. On imaging wise, accidentally detected to be intrahepatic cholangiocarcinoma. What plan you will do? Whether you will give a conservative, whether you will plan for liver transplant?
No, this question actually should come to Dr. Kumar. But if it is a small compensated HCC, compensated cirrhotic patient or non-cirrhotic, ideally we'll go for resection because, unless we're talking about LDLT, our patients, Dr. Kumar can also add to it. In America, it's very hard to get exception points so that they can get easy transplant. If the patient is well compensated hepatitis B, and we can control Hep B with medication, and resection is possible, I'll go for resection.
After the therapy of local regional therapy or the resection, if further patient decompensate, what you will do?
Well, if the patient decompensates, then obviously you have to go for rest salvage and transplant.
Okay.
There is no other option.
Thank you, sir.
Thank you very much. I think we had wonderful 2 talks and questions, interaction. We'll move on to the last. Thank you, Dr. Abhi and Dr. Prasoon, for wonderful talks. Thank you very much.
Thank you.
Thank you. And now I have the pleasure of inviting Dr. S.K. Sinha, the Professor of Gastroenterology from Department of Gastroenterology and Hepatology, PGIMR, Chandigarh.
Thank you, sir. Thank you so much. And thank you, Professor Sareen, for giving me the opportunity to be here. I'm going to discuss a little bit of recent literature on what is new in biliary tract cancers. So resectable cancers, there are not much of issues. They go for surgery, either transplant or resection. So there not much of action is going on. What action is going on is actually in the non-resectable, and there the systemic chemotherapy, combination chemotherapy was the norm, and from there we are progressing to the targeted therapy and to the immunotherapy. So lots of things are happening. Or for the targeted therapy, we need to have the targets. So what are the targets? So targets are different in intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and in gallbladder carcinoma. So we need to, these are the targets which have been described, and every day new targets are appearing. And the methods of detecting these targets, that is also changing. So I'm going to show a little bit of that. And these targets are important because we have to define these target to target our treatment. For some of the targets, we have the molecules. For other targets, the molecules are yet to be discovered. So we expect those molecules will come in future. So this is some of the algorithms which are evolving now based on these things, and people have started making, so that is happening. So already there are lots of, because targeted therapy will require targets, and then chemotherapy is given for that. Immunotherapy can be given as such. That doesn't essentially require a target, and then immunotherapy can be combined with conventional chemotherapy or targeted chemotherapy. So lots of trials have started appearing. Some are summarized here. So we see that lots of things are in the horizon, and things will become crystallized over period of time. So these are some of the trials. This is what is evolving is now being termed as precision therapy. So depending on the target, we precisely give those molecules. So depending on the target detected, these targets are not detected in every tumor. These are detected in only a small percentage of tumor, and accordingly we make choice. So that has become the norm, or that is the future which is coming up. So as we see that previously the gemcitabine, cisplatin was the norm, and then subsequently capecitabine and the therapy has evolved, and now we are evolving to the level of targeted therapy and the immunotherapy. So immunotherapy, I'm going to discuss a little more, lots of information, and that has reached to the level of changing the guideline and algorithm. So what has happened, that this is the title of the editorial which appeared this year only, few months back. So lots of trial, at least 3 large trials have appeared on immunotherapy, Topaz, Keynote, and one unnamed trial, these 3 trials. So Topaz is the landmark trial, so very large size trial, almost more than almost 700 patients included, and this across continent, so the data will be valid virtually, this will be global data. So that's why it's important. And if we say pretty long follow-up, 24 months follow-up data we have, either with conventional chemotherapy or with combined with immunotherapy. And what we see that there was 25% risk reduction in disease progression and 20% risk reduction in terms of death. So that is, both are significant. So that is pretty important. So what is important, the next important is whether at what cost we are getting. Cost I'm not talking of in terms of money, but I'm talking in terms of adverse reaction. So adverse reactions, we see that that is pretty acceptable. So obviously this is going to be the standard of care. And if we get to see the adverse reaction, these are pretty minor adverse reactions which are happening. Keynote, another agent for immunotherapy, but here the results are not so gratifying as we see in the topaz, but still it was significant, but the difference was minor. Another trial, and this was still more significant. So this is with gemcitabine cisplatin, which is the standard of care chemotherapy combined with immunotherapy, and shows clarity, and again the side effect profile was acceptable. So these three trials puts immunotherapy combined with chemotherapy as possibly the first line therapy for these tumors. So then there are certain difficult situations when patients come with failed therapy or advanced therapy. Then we have combination of PD-1 blockade and lenvatinib. So that that has been done. So this is basically what they are doing. They are combining the immunotherapy and combining with the targeted therapy. But targeted therapy we always have to do with the target. So only those tumors which are positive, they will show more results. So on the left hand side, we see the results were maximum in those who were PD-L1 showed expression. So there those were responding better. So obviously this leads to a situation where we will like to predict what tumor is going to respond. So now people have come up with a model based on multiple factors that we can predict beforehand. So here they have described a model where they have different parameters, including nutrition and other things, and the markers, and beforehand that can be predicted. So this can be very useful clinical markers. So, but for doing targeted therapy, we need to have the target. So mostly that is done by next-gen sequencing. So that is mostly done on aspirated or biopsy material. So we require a tissue. So that is a cumbersome exercise. So that provides genetic information. But we know that tumor cells are shed in the blood, and that can be used. So this study showed into the cell-free sample that whether these studies can be done. And interestingly, this is a medium size sample size study, and interestingly very high percentage of patients, the figure often will appear even more than the tissue sample positivity rate and the same information. Obviously we have many advantages here, that and they compared it with the tissue sample, and there were high degree of correlation, 87 to 100% these things. So this gives us tremendous advantage, because every time we need not go to the tissue and aspirate or take a biopsy and study. We can take from the blood and study. Deviating from such complex things, something simpler. Traditionally, the cholangiocarcinoma and hilar cholangiocarcinoma are not the cancer which has been discussed in the setting of smoking. New data coming up from Japan, and they have shown that association, that the risk is higher, not phenomenally high, but the risk is definitely higher in a smoker. So one more cancer gets added to that. Then interesting data that this is the study in which they showed that renin-angiotensin inhibitors, cholangiocarcinoma, they not only improved survival, the survival was improved, and disease-free progression was also improved with the use of renin-angiotensin inhibitors. So most of these patients were hypertensive patients. So those who are receiving renin-angiotensin inhibitors, they did better compared to the other agents. So there is explanation for that, and this information has been seen earlier in other tumors also, because the biliary epithelium is known to express angiotensin 2. So that has some pathways on which we can explain. So one very common problem which we face, that many of these patients actually require biliary drainage even without cholangitis for the purpose of giving chemotherapy. So when we do biliary drainage, obviously in the obstructed biliary system, we need to give antibiotic beforehand. So what should be the timing? This is a very interesting study. They looked for timing which affects the outcome. So it is the 1 hour period just prior to the procedure, which is the golden time when the antibiotic should be given. And if we give much before, the results are inferior. So there is more complication to the infection. Then again, some very simple things like osteosarcopenia is a strong prognostic factor for biliary tract cancer. It affects recurrence as well as progression. Progression was expected, but importantly, recurrence was also more when there was osteosarcopenia. So those are the other points which are relevant. So I will summarize by saying that now we are moving forward, and this is one of the algorithm reported by one of the group. And this is, you see the first line therapy changing now from gemcitabine cisplatin to combining it with the immunotherapy, and subsequently there will be, if targeted therapy is available, targeted therapy can be tried, and then subsequent lines also the targeted therapy can be used. Thank you.
Thank you, Professor Sinha. If there are any burning questions from the audience, please. Yeah, please.
Yeah, it's a good presentation. So my specific question, Dr. Sinha, this angiotensin promotes this tumor progression. So my question is it targets tumor cells or it targets stromal cells? For example, cancer-associated fibroblast or tumor-associated fibroblast.
Renin angiotensin inhibitors delays progression, so no, it will not augment progression.
That is my second question.
So
that renin angiotensin inhibitor, particularly angiotensin converting enzyme inhibitor, ACE inhibitor, that blocks the tumor progression, regress the tumor progression. But angiotensin 1 promotes tumor progression. There are a lot of literature.
Yeah.
So
right.
my question to you is, targets tumor cells or it targets stromal cells within the tumor microenvironment?
No clear answer. Because in other sites also this has been shown to be effective. That data, if one can go for projection. So this effect has also been seen in breast cancer. This effect also has been shown in the ovarian cancer. So this is possibly the combined effect on the inflammatory reaction at the tumor level as well as the tumor tissue.
Hello, it's a very good presentation. My question is, this giving an antibiotic 1 hour before the procedure is advantage. What is the basis behind it? Whether he has taken antibiotic earlier or you will give the fast dose before starting the procedure? Because fast dose will not work within 1 hour. What is the basis behind it?
They have not talked about the first dose, but the dose within 1 hour of the procedure is important.
Okay, previously is getting the antibiotic.
So if somebody is getting, say for somebody is already getting antibiotic, has been given 12 hours before or 8 hours before, possibly it may be point giving 1 hour, because that is the window period which will give you maximum efficacy.
Suppose he has not taken any antibiotic earlier, they will start within 1 hour.
This is for non-cholangitic patient. Cholangitic patients are supposed to be on antibiotic. So they are not supposed to be on antibiotic. So the question addressed was, in that particular study, was we should be giving 6 hours before, we should be giving 12 hours before, we should be giving post-procedure. So if you see the study, that then there is 1 hour, 1 to 3 hours, 3 to 8 hours, and no prophylaxis. So these are the 4 arms of the study.
Thank you, Professor Sinha. I think it was only prophylactic antibiotics before ERCP, before biliary drainage. Let me clarify that. It was 1 hour, given within 1 hour of a procedure is what they said. Thank you very much for wonderful review of the literature. And India is on the verge of winning the cricket match, so I think it's a good time
so we have won the match, sir. quiz session is not there, so we can conclude this session, sir.
I think the quiz is cancelled and we can close the session.
Yes.
Thank you very much. We would like to thank our panelists and co-chairpersons, please.
Thank you to the chairpersons, moderators and the speakers. I request all the delegates to gather after half an hour in the same hall. We shall be rearranging the hall we need half an hour for that, and then we will have a musical program along with the gala dinner.